Good morning. I want to ask all of us to please turn off cell phones and or make them silent. And for the board members, please take them off the tables. You may notice board members accessing their laptops during the meeting. They're using the laptops for the purpose of looking at the board materials in electronic format. This is an official business meeting of the Medical Board of California. As such, disruptions of the board business will not be tolerated. We have a designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask the person to conduct him or herself in such a manner that permits the board to transact its business. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconference process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. To request to make a comment during the public comment period, press *1. You will hear a tone indicating you are in the queue for comment. If you change your mind and do not want to make a comment, press #. Assistance is available throughout the teleconference meeting. To request a specialist, press *0. Each person will be limited to 3 minutes per agenda item. During the agenda item 16, public comments on items not on the agenda, the board has limited the public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. Business services staff will be assisting me with receiving the public comments via teleconference during this meeting. The board welcomes public comment on any item on the agenda, and it is the board intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on the agenda item, you wish to speak on that item, please raise your hand or come forward and you will be recognized. I would like to request all speakers to complete presenter slips so I can call on you by name at the appropriate time and the record of this meeting can be full and complete. However, this is voluntary. Please give the speaker a slip to Ms. Toof. Ms. Toof, I'll do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make last-minute comment. We plan to end today's meeting. It says at 2 p.m. I say it's 1 p.m. today. Kim will introduce the guests. Kim, please go ahead.
I'd like to introduce Christine Lawley, who's the Deputy Director for Board and Bureau Relations at DCA. And then also Karen Fisher is here, the Executive Officer of the Dental Board. And then we'll be hearing from her in a moment, but we actually are honored to have Dr. Smith from the California Department of Public Health. She's the director over there, and we're lucky to have her here with us today.
Thank you. Welcome to Medical Board. Now I would like to call the meeting to the order. Ms. Toof, for roll call, please.
Dr. Bolott? Present. Dr. Bishop?
Here.
Judge Feinstein?
Here.
Dr. Hawkins?
Here.
Dr. Kraus?
Present.
Ms. Lawson?
Here.
Dr. Levine?
Here.
Dr. Lewis?
Present.
Ms. Pines?
Here.
Ms. Sutton-Wills?
Here.
Mr. Warmoth?
Here.
Ms. Wright? Dr. Yip?
Here.
Dr. Gonadev?
Here.
Thank you.
Thank you. We have quorum. I would like to remind the members again that we will be taking a roll call and vote on all action items. Moving to agenda item 15, public comments not on the agenda. I have one slip. Okay, that's 24. Okay, I'm sorry. Any public comment on items not on the agenda from the audience? On the telephones?
Comments on the line?
No comment.
Thank you. Anyone here, Kim? Okay. So the next agenda item is item number 16, a presentation on the statewide prescription opioid misuse and overdose prevention work group and the Office of Health Equity. I'd like to take this opportunity to introduce Dr. Smith. Dr. Smith is the Director of California Department of Public Health and State Public Health Officer. Dr. Smith specializes in infectious disease and public health. Prior to her appointment, Dr. Smith served as Public Health Officer and Deputy Director of Napa County Health and Human Services Agency and was on medical staff for infectious diseases at Queen of the Valley Medical Center in Napa. Dr. Smith also served as a clinical faculty at the Santa Clara County Valley Medical Center, Division of Infectious Diseases, and as an Assistant Section Chief of the California Department of Health Services Tuberculosis Control Branch. Dr. Smith completed her medical training and infectious diseases fellowship at Stanford University after having obtained a Master's of Public Health degree at Johns Hopkins School of Medicine, Hygiene and Public Health. Dr. Smith also served in the Peace Corps as Public Health Laboratory Director for the Marrakech province in Morocco and at the Vichenburi Regional Hospital in Thailand. I want to personally thank Dr. Smith and CDPH for work they have done on the opioid misuse and abuse epidemic. Dr. Smith, it's our pleasure.
Thank you very much. I'm honored to be here to speak to the board today. I'm going to, respecting your very busy agenda, give you a very high-level overview in hopes of leaving some time for questions. I'm going to talk first about the statewide prescription opioid misuse and overdose prevention work group, a name that just trips right off the tongue. I'm going to describe first what the work group is currently doing, and then talk to the very pivotal role that the medical board has played in this working group. Because I have to, it's a requirement whenever I speak, I'm going to show you some data. I'm kidding, sorry. This is just to point out that we have seen a little bit of a decrease. This is mortality rates from, on the top line is prescription opioids and the bottom line is heroin. And that we did see a slight decrease, but now flattening off of mortality rates for prescription opioids. Beginning in about 2009, but the rate of heroin overdoses leading to death is continuing to increase. This slide, I think, is actually even more pertinent to the board's work in that this shows you the relationship between opioid prescriptions and emergency department visits over the past few years. And as you can see, there continues to be a slow but steady increase, despite the fact that the number of morphine milligram equivalents of prescription opioids per patient has decreased. We're really not making very good inroads into the required. These are folks who actually go to the emergency department, many of them with an overdose or significant over-medication. Just a little background on the work group itself. In 2013, the CDC declared that there was a nationwide epidemic of prescription drug misuse, and in particular referring to opioid-based drugs. In spring of 2014, actually in response to a call to action by the Association of State and Territorial Health Officers, my predecessor, Dr. Chapman, called together all the relevant agencies within the administration to say, what can we as state entities do about this problem? And can we coordinate those activities and be sure that we're sharing information so that rather than working at cross purposes or in parallel, we're actually going to gain some synergies. And so that was the initial few years was exactly that, a state level, state agency collaborative process. It's expanded considerably since that time. We have maintained that conversation amongst state agencies, but we've also broadened the work group to include other partners who are actively engaged. There are over 20 agencies, so I won't list them for you, but I will say that, interestingly enough, our first request to join was from the DEA. And because they recognize that their single approach of law enforcement wasn't going to be meet their mission of decreasing the amount of, in particular, illegal drug use there was in California. So the multi-sector collaboration that we have going is based on 5 key principles: achieving safe prescribing, access to treatment for persons who have opioid addictions, naloxone distribution to prevent death, public education to make the entire public aware of the issues around opioids, and because it is affecting so many families, and then using data in a way that both forwards our work, but making that data available to the general public. And I won't do a show and tell for you, but I do have one slide to talk about that. So currently, the work group has 20 plus members, and is now, the perhaps most exciting part is that through a partnership with CHCF, California Healthcare Foundation, and with funding from the CDC, CHCF, the Department of Justice, and SAMHSA, we have a very robust partnership with over 25 local coalitions. These are either county or regional coalitions of law enforcement, public health, the healthcare sector, prescribers, pharmacists, et cetera, working in their area to take the tools that we're creating and that are available elsewhere to really address the problem that is specific. As you can imagine, LA County is a little bit different than Tulare County or Shasta. And so these regional coalitions have really started to take off and are making really good inroads. The other key partner there that I neglected to mention and shouldn't have been the managed care providers, the insurance companies themselves. They have tremendous power, as you can imagine, to implement change in prescribing. And most recently, because we've had such a huge increase in number of partners in the work group, we've been able to actually create 4 separate task forces with 4 action plans, and I'll mention a little bit of just not what each of them is doing. There's one that's focusing on the healthcare policy piece of it. How do we ensure that physicians both have the information they need, but then also prescribe appropriately? Communications and outreach, and that's to all sectors. Treatment, specifically, this is medication-assisted treatment for persons with addiction, and then making sure that we're gathering data and making it available in a format that people can actually use. So just to hit some of the key things that the work groups are doing, we will be having a summit in May of 2017. You're all invited. We're going to bring together best practices, leaders from both healthcare system but also other partners to share strategies and solutions and create some best practices that we can agree upon across the state of California, in particular around safe prescribing, but also increasing the use of the CURES database, which is our prescription drug monitoring database, and which has had a huge improvement over the past 2 years. It's really become a very user-friendly. I know I had to sign up as well as everyone else, and so I actually went in and used the system, and it's actually it's much better than it was, and the data that it's putting out is really helping to inform our work. We're also going to be looking at the summit access to treatment for addiction. Really exciting for me, a thing that we're doing in partnership with UC is academic detailing. So the work group is actually creating a curriculum for practicing physicians that they will then take to physicians' offices, just as your friendly neighborhood pharmaceutical company does, and really speak directly to physicians and other clinicians to answer their questions about their practice and provide very specific expert advice. We're hoping that that's going to really have good uptake and be useful to physicians, and if it is, then we'll be seeking funding to expand that. The Communications Task Force has combined funds from the Department of Healthcare Services Substance Use Policy and Prevention Division, as well as some of our CDC funding, and we will be creating a statewide awareness and education campaign, which will hopefully deliver compelling messages to the general public to be aware of the issue and what to look for, and hopefully shifting some consumer and patient attitudes and behavior. And then we are doing a policy scan, an environmental scan of policy, to try to look at what's working and what the work group can do to support and promote and facilitate really systemic change through policy. And the treatment task force is actually tracking and monitoring new medically assisted treatment initiatives and naloxone distribution sites across the state. We're in the process of creating a web-based application so that wherever you live, based by zip code, we can provide you with information over the web for you to provide to patients, for physicians to provide to patients, and for their own information. And then our data gathering and sharing task force is working with multiple state agencies to define standard measures of performance in this area of opioid misuse and abuse so that we can monitor our progress as a state. So the really fun stuff, I know that the URL is weird. It's down at the bottom there. I strongly encourage you to check out our opioid surveillance dashboard. This is an interactive dashboard where you can both drill down on any given indicator into a state, into a county, and in some cases, city level data. Then you can also look at and flip with one single click. You can flip from mortality rates to prescription rates to ER visit rates, et cetera. And so it's really a very powerful tool and helps to inform you about what's happening in the area where you're practicing, but also has statewide data. This is just a static view, but it's a pretty easy to follow database. So I want to switch gears really quickly to talk about the role which the medical board has played. From the very beginning, the medical board's been a key partner and was one of the first partners in the working group. And they have really been a leader from the very beginning. The first most obvious thing that the medical board did was to release their revised guidelines for prescribing. And this it came out long before the CDC had theirs. Congratulations. And it is an example of the sorts of materials that we have posted. The way that we've coordinated between state agencies is each of the websites where these materials are linked to the others, and they all have a similar look and feel. And that's designed to provide the impression and with the reality of the fact that the state is working together so that you know when you see that look and feel, the color palette, the fonts, et cetera, but also the quality of the materials that will be there and that it's a reliable resource. And then because the CDC did subsequently come out with guidelines, and they do differ in some small ways, the medical board took on the task of doing a side-by-side comparison, which has been extremely helpful. And really the bottom line is that there are a few differences. They're not major in general, and the two complement each other. They actually have a slightly different focus, and so if used together, they really can be a very effective tool for prescribers. The other thing is the medical board has helped us with a Cures user attitude survey. This is a way that we're tracking how successful the Department of Justice's funded Cures database is. They are continuously improving it, and they're using the information that they get back from users to actually do that. And the medical board's been a major contributor to implementing and maintaining that survey and promoting participation in the survey, because we all know that as a general rule, physicians do not respond to surveys in high numbers, but actually getting really good feedback on this. And the board continues to work actively and participates and comes to attendance at pretty much every single meeting, which I really appreciate, that they have been such a key partner and participating on many of the different task forces in a regular way. We could not have been, none of us could have done what we've done so far in California and without the participation of the medical board. So thank you all very, very much for that. Do we want to take questions now or wait until the very end? It's probably good to take a few questions right now. Yeah.
Yeah.
Yes, please.
Dr. Lewis.
Hi, Dr. Smith. Thank you for the most enlightening presentation about this important healthcare concern. I was looking through your slides, and what I didn't see, unless I missed it, was collaboration with pharma. Mm-hmm. Because, recently Everett, Washington has now sued Purdue Pharmaceuticals for being responsible for their addiction epidemic in their city. And we all see in the paper, Purdue this, Purdue that, OxyContin. But I don't see pharma. They're not always the bad guys. So where's your collaboration?
During the first few years of the work group, because it was a state agency exclusive until I came. There was no role for any external partner. Since that time, we've been adding partners largely upon their request rather than us going out to solicit partnership. And we've only just gotten to a point where we have sort of stable action plans. I think your point is really well taken. You're absolutely right. We do need pharma to be at the table, both to hear their perspective, but also to engage them in actively mitigating this particular public health challenge. And so as we move forward over the next year, I think particularly in the policy realm, I take your advice, and I think we will be reaching out to pharma more actively than we have been. And you're right, basically, and we will.
Okay, thank you.
Thank you, Dr. Smith. Actually, we think that our guidelines are much better than CDC.
So do I, actually. So do I.
And I want to publicly thank Dr. Bishop for working pretty hard on those things. So.
And Kim and the staff at the medical board really were the heart and soul of that too. Thank you.
Thanks, Mike. Yeah. So let me ask you this thing. I know the entire country is going after the prescription opioid abuse, which looks like it's actually somewhat slowing down compared to what the rate of growth before. Mm-hmm. My concern is the rapid growth in the non-prescription fentanyl illegally coming out of probably China through the southern border, where the fentanyl, according to the production where it is done, it could be as high as 100 times more powerful than morphine. So what are we doing on that?
So that's you're absolutely right. That is one of the reasons we have heroin up on that first slide, is that's the only drug for which we actually have ICD-10 codes. So just to begin the conversation from our perspective as opposed to law enforcement, it's really hard to get a handle on just how big the problem is. We don't have good tools for surveillance for these sort of synthetic fentanyls, if you will. We had a huge problem, I think you're probably all aware, in Sacramento last year. When that happened, we in the health department did what we typically do when we see an outbreak of anything, which was attempt to do surveillance for this substance throughout the state. And that led us to discover that we have huge problems. It's not tested for regularly. It's not reported, and overdose deaths overdoses are not well reported. We pull that information, but we don't get that information and report it. It's a passive pull for us from the ED records from the Office of Statewide Health Planning and Development, OSHPD. So just getting a handle on where it is and what's happening is a big challenge. We actually, because it was so stark in Sacramento, we reached out to the DEA, our partners, and had a conversation. We wanted to know, because we were worried that people were going to die if it moved out from Sacramento. So we were trying to figure out, who do we warn, where do we put out health alerts, which doctors should we notify. We try not to send things out statewide when they're localized, because people then just throw everything we send out into the round bin. But the DEA themselves had no idea. And so it's an issue we're struggling with internally. We have a couple of CDC grants, actually, and that specifically is something that we put in. CDC is similarly trying to figure out how to get to prescription, other drugs besides just the generic category of opioid, which you have opioids, heroin, and marijuana, and that's it for coding. And so somehow we've got to change that, whether it's a voluntary thing, and it would probably be emergency departments, or the other thing that we're trying to do is reach out to local law enforcement and get better data from them on what they see, as well as EMS agencies. Because if you limit yourself to what's happening in hospitals, what you miss are the people who overdose, get naloxone in the field, whether it's through law enforcement in a few places or more likely EMS, and those don't get reported at all. So it's a really interesting and difficult issue for monitoring. And if you can't monitor, it's hard to know how to stop it. Perhaps the border wall will help. It is coming in it is coming from China, but it's coming in through Mexico, according to the DEA.
That's what DEA people told me exactly what you said. They said they were somewhat lost. They were trying to figure out how to stop it. So that's fairly concerning because the numbers are going up, and it's a lot cheaper than street value is a lot cheaper than prescription drugs which are sold on the street. So that's
Right.
that's
And
concerning.
as we're more successful with the safe prescribing and decreasing prescribing practices, we're driving some individuals into that illicit market where they're at greater risk. And that we saw that happen in very stark ways in Indiana. We're trying very hard to be cognizant about that and make sure that we have some mitigating interventions in place when we do start really ratcheting down.
Thank you. I'm glad you were on that one. Dr. Hawkins.
Thank you very much again, and thanks for providing those resources. I'm in private practice in Inglewood, so I'm confronted with this all the time. The guidelines are very, very helpful. I particularly like our guidelines. Any of the task force, and I believe the answer, I know the answer, looking at trying to generate better, more user-friendly approaches to solving and being a better provider, opiate use, avoiding abuse, taking care of pain for the doctors. We're overwhelmed, inundated with things we have to do and check and read and review and provide. And I know that we're seeing this in our national symposium more, but I wonder if any of the task force are really trying to directly help physicians develop ways to really approach it efficiently as we're asked to do more and more things.
Yeah, I think that actually is exactly the intent of the academic detailing piece. And while that will start small, hopefully we'll be able to reach out to more physicians because each physician practice is unique and the questions that those providers have are different because their patient populations are different. And it's one thing to say, here's how to prescribe opioids. It's another thing to say, how do you talk to your patient who's been on X for a really, really, really long time? That's the kind of thing also that we're going to be addressing in the symposium or the big meeting, the summit, I think they're calling it, in May. Because there are models out there that have gotten traction in certain areas, and what we're interested in from the state level is what's really working that we can then find a way to expand that so it's more accessible to providers. I think it's the sort of thing we're going to have to bring into the other ways that we educate providers about new and upcoming issues. For me, I think I never actually, because I was infectious diseases, had to practice, but the questions that I don't know how to answer is, well, what do I do about their pain? Because there really aren't, it's not like there are pain specialists everywhere available, particularly in the areas where we have the highest issues with overdose. And so what are the legitimate options that are really going to be successful? So I think it's an excellent point.
Do we have a date for that May meeting?
I don't have it with me. We'll make sure Kimberly has it. I'm not sure that the exact date's been landed on, but I know that they're building out the agenda right now. So,
Thank you.
Dr. Bola.
Thank you very much, Dr. Smith. A couple of questions for you, and those are regarding the task force that you have. And one of the key areas, as you mentioned, are the emergency rooms. And there have been initiatives in various parts of this state to try to get the emergency room doctors all on the same page so that on Friday night someone doesn't come in for a squirt of Dilaudid and get out the door. So how much representation do you have with emergency medicine on your task force? Because it's a portal of entry for many patients to continue to receive their opioids.
So in terms of individual physicians from emergency departments on the task force, I don't think we have anyone specifically, but what we do have is California Healthcare Foundation. They're the ones who are coordinating and working with these regional coalitions, and that's where that conversation is happening, because the areas that have been very successful, San Diego, Los Angeles, Marin, for example, are actively sharing. We have a learning community through these 27 coalitions and an expert advisory panel, which includes a number of emergency room physicians who actually have taken this on as their specialty. So they're doing a lot of peer-to-peer training and working with the coalitions that's one of the first interventions in the list of here's what, if you really want to take this on in your community, one of the first things you need to do is connect your emergency room physicians up with the following groups. And so, yeah, it's really key to keeping that kind of backdoor into maintaining your opioid supply from
Right,
happening.
and I think the point would be if in any way to encourage the task force to do this, because I do live in LA County and I am on one of those task force, so I am familiar with what happens. And I think, though, that your first slide really points to this need of our really addressing those emergency room physicians. And I think, to Dr. Hawkins' point, oftentimes it's not going to be the pain specialist that is going to be treating the patient. It's going to be someone showing up, and the doctor runs the cures, and then they go, gee, what do I do? And so that academic group that's going to be getting together, I think having the voices of many people, which I'm sure you have, is going to be really crucial. I work in an academic institution, and people are, challenged every day with how do I deal with a patient that has chronic non-malignant pain? And then what do we do for special subpopulations? We have a large community of individuals that suffer from sickle cell, and they go into crisis. Now, how does that get interpreted? And so we've had various things that I think your work is really important, and I too will look to Kim to get the May date. Thank you very much.
Yeah, I'm very excited about the potential to have specialty groups, in particular ED physicians being one of the most important, begin to work together statewide. And that's the sort of thing the task force can facilitate through some of our grant funding.
Thank you.
One thing is, I know when I think it was the San Diego one that first started that safe prescribing guidelines for the ER. I think that they're the ones that first came out with that. I know that the work group actually, we brought that in so we could actually support that as the work group, and got that out, I think, on most of our websites. So that is one way we did work with them, yeah.
I think we also have to go through the professional organizations until you have their sort of blessing and buy-in. It becomes difficult to do doctor by doctor work.
Thank you. You have another right?
I do, if we still have time.
And I'll ask for public comment afterwards, after both items are done. Thank you.
So I was asked to talk to you a little bit about the Office of Health Equity, which is in the director's office at the California Department of Public Health. I always like to start with what health equity means. This is the definition of health equity that is from the California Health and Safety Code that established the Office of Health Equity. But when people ask me what it means, it's to have achieved health equity would be for everyone in a community to have an equal opportunity to be healthy, essentially. And so that is, in a nutshell, the mission of the Office of Health Equity is to work toward, in many different ways, achieving a California where everyone has an opportunity, an equal opportunity to be healthy. I'm not going to go through all this. I provided that to you so you could, for those of you who are really interested, it's a very long and complicated mission and mandated activities, but we can boil them down, I think, a little bit. I'm going to just tell you what the different parts of the office are, and to, in that way, kind of demonstrate the span of things that we're doing. So we have 3 units within the office: the Community Development Engagement Unit, the Policy Unit, and the Health Research and Statistics Unit. It was very interesting to me when I came that mental health and achieving equity in mental health was such a prominent part of the mission of the Office of Health Equity. And I was not really aware of the conversation in Sacramento around developing the Office of Health Equity. But I think it was at first surprising, and now I'm actually really impressed at the foresight that the people who created the Office of Health Equity showed in that. Within the community development, whatever the name of our CDEU, which is, there it is, Community Development and Engagement Unit, the focus is kind of twofold. Providing technical assistance to other state departments in their mission to actually become more culturally, linguistically, and other competencies in mental health specifically, because mental health is so sensitive to the differences in populations and just simply ineffective if you don't take that into consideration. by far, the biggest part of the work that we're doing in the Office of Health Equity overall is within this realm, and that is the California Reducing Disparities Project, which is a name that doesn't really describe very well what the project does. This is $60 million of Mental Health Services Act money that is going to small groups, small community groups that have been working already in the realm of mental health and reducing stigma in specific subpopulations of the group that were chosen by an advisory committee. What we're doing is funding those groups to both do the work that they have seen work, but more importantly for me as a scientist, we're funding them to increase their capacity to evaluate that work with true outcome evaluation so that we can begin to build an evidence base. There is simply no evidence base for community interventions in mental health. And so when you're trying to apply for grants at the federal level, it's virtually impossible when everybody wants an evidence-based practice with that very restrictive definition of an evidence-based practice. And so in particular, small groups who make up the bulk of the groups that are actually actively intervening in communities are completely locked out of the picture. So that's what this, and I invite you, there's a whole website on the CRDP, and I invite you to check that out to get a little bit more information. But that's by far the largest bit of work within that unit. Although we do have a group that also provides technical assistance across the state. Okay, now let's get to the policy unit. Oops, I went back. In the policy unit, the intent of this unit is to meet the requirements of the statute to look at policy and assess the degree to which policy and proposed policies are actually helping to achieve equity as opposed to inadvertently creating greater disparities and inequities. The bulk of the work here at this early stage in the department is actually in the health and all policies work. So along with the Sustainability Council, Governor Schwarzenegger created the Health and All Policies Task Force. The Health and All Policies Task Force is an interdisciplinary task force whose job it is to look at policies that are being proposed across sectors and saying, are there unintended or good health impacts of these policies? So whether you're making land use policy, transportation policy, or any other environmental policy, what are the effects on human health of this policy? And our team, which is 8 people, actively sits on both on the council, but then also we staff the task force and create policy statements, and we assess policy from a very strictly human health outcome lens for other departments and for the council overall. And it's very exciting. Health and All Policies is started actually in Australia. It's used in many countries around the world, but it's a way of, it's not directing policy from a health perspective. It's saying when you make policy, you really have to be intentional about what the health outcomes of that policy is going to be, because health, as we know now, is not just about medicine. It's also about the conditions in which you live, and we're making policy around those conditions. And so there's a great deal of work that we do on that. The other thing that we have done is actually do a rigorous assessment of indicators for healthy communities. So when people are working, doing healthy communities work, for example, our Accountable Communities for Health, how do you measure progress? And so we started with almost 300 potential indicators of a healthy community, and have done a really rigorous analysis of the strength of the indicator, its sustainability. Is it actually an indicator of what you want to measure? And have created a data set which we are beginning to gather the data on, that we will be able to sort of put out in geomapping the way we do much of our stuff. But it's still not quite done, but very close to done. I'm excited about that, having come from a place where we were working actively in Napa County on creating a healthy community and engaging a lot of sectors in that work, and having the ability to say, yes, it's making a difference, is huge to sustaining that kind of work. And then the final unit is the Health Resources and Statistics unit. This is the group that does a lot of the work on indicators, but also tries to understand. It's doing the more forward-thinking work of what should we be looking at, what should we be measuring as we move forward, as opposed to what do we already know to measure, and as well as doing a lot of the actual statistical analysis. The other piece that's still under development, but I think very important, is this term vulnerable communities is used a lot, and it's beginning to be used in order to make decisions about funding with huge amount of money. In particular, if you look at Cal EPA and the carbon tax and the way that money's being proportionately put out. And it is targeted at vulnerable communities, but right now the definition of a vulnerable community has to do with transit and how close that community is to the potential for things like air pollution and noise pollution. There is a pretty loud voice that says that really we need to be looking at other measures of vulnerability in terms of communities that also should be funded. And so it rapidly becomes a very political conversation when you have money. So what we're trying to do is actually find a data and science-based way of saying, what is a vulnerable community? And there won't be one answer to that, obviously, but it's a very interesting kind of carefully done study. And then finally, equity, and I love this slide because it demonstrates to people the difference between equality. When you talk about health equity, people are like, well, everybody has the same access to health care. Isn't that enough? So A, I would challenge that as actually being factual, but B, it's not enough because not everybody doesn't need the same in order to have an equal chance of being healthy. So thank you very much. I'm happy to take questions if you have
Thank
any.
you. Actually, you touched on a pretty important subject, which is, at least for me, very close to my heart. We're even creating a department at the medical school I'm starting on the social determinants of health.
Excellent.
That's where actually it is going. If you look at whether it is mental health or mortality from high blood pressure or diabetes or cancer, heart disease, almost all of them have some relationship to the social and economic factors.
Absolutely.
It is so important that state of California is actually CDPH is taking this on, and hopefully we can get some grant funding in the appropriate, not just the environment alone, because I think that's a little more controversial, but I think it's the poverty.
Yes.
Mental health. These are the big issues, especially in the inner city neighborhoods or in the very rural areas. So that's why it's very important. Thank you. We really appreciate it. Any questions? Dr. Levine.
One thing you didn't mention was violence prevention. Is that anywhere in these plans?
So violence prevention isn't specifically in the Office of Health Equity plans, but we have a very robust violence prevention working group actually within the department. We have a number of, we're very siloed because of funding, and we're working to fight that. And one of the things that happened was we had violence prevention in a number of different areas. We have rape prevention, we have gun violence, so they're all sort of separated. After San Bernardino, there was a big cry for what is public health doing about violence. And so we actually initiated a formal planning process for the department on how we should be approaching violence as a department as opposed to individual programs. And so we have a very robust plan. It's a very concrete action plan that we're actively pursuing on how to have a more comprehensive approach to violence, because it is so incredibly important in terms of, particularly for children. A lot of our work is around ACEs and trauma-informed care as well, and so there's an interplay, and violence is one of those areas where all the different pieces of what we do in public health are both impacted but also can positively impact the issue. So it's a hugely important issue to us that we're beginning to really try to figure out how within existing resources to take it on in a more comprehensive way.
Is the work of the First Five Commission part of this?
Well, right now we're working internally, but yes. So our partners in the Center for Family Health work actively with First Five Commission, both at local level but also at the state level, on all of the issues in family health that they're working on. And this is obviously deeply part of that whole issue.
Judge Feinstein.
Hi there, and
Hi.
I thank you for being here today and found your presentation most interesting. I want to focus, since you brought it up, on mental health, and particularly on mental health as it pertains to children and adolescents. We are doing a horrible job as a state in meeting their needs. And there are, I wish I had the numbers with me, but I don't. There are continual, ongoing closures of residential facilities, subacute and level 14 facilities, because the Medi-Cal reimbursement rate is so very low that the facilities can't be maintained. And we are shipping children to Utah, where people that work in these facilities are paid $7.25 an hour, thereby defeating family relationships, family reunification, all sorts of things. And it's particularly true in our cities. But I hear all this talk about mental health care parity, which does not exist. And I would like to know what your group is doing about this, because all these young people, with whatever their mental health issues are either going to be in our schools, on our streets, or worse, if we don't start serving them better. And we're doing I can't think of a state that's doing it worse. I'm sure there's one out there. But
yes,
the
there
big
are.
states, the big states are doing a much better job than we are.
Well, we could talk about Texas, but
No, we're doing a terrible job.
no, I do not. So I could be a choir of one. I have a stepson who lives in a group home, severely mentally disabled, and another stepson who has chronic paranoid schizophrenia. I am, for 25 years, very familiar with the mental health system in California and its inadequacies. This isn't a dodge, but I do have to say that while within the Office of Health Equity, we do have this particular Mental Health Services Act program, mental health services overall are actually managed out of the Department of Health Care Services, which is also where Medi-Cal is. So they have Medi-Cal, substance abuse, and mental health within the Department of Health Care Services, which, while in the same agency, is not under my scope. Also, there's the Department of Rehabilitation. So you touched on several different departments.
Maybe that's the problem.
It is a very large part of the problem. I agree with you. I don't have easy answers. I don't think there's anybody working in the administration who is not, at least in our agency, who's not aware of just how insufficient the system is. I have to say that it is the one thing that keeps me up at night, is that it doesn't feel like we're making progress. And I like to at least feel like we're making progress on these big social issues. I think you've touched on something incredibly important. And if you're interested and would like to give me your card, I will connect you up with somebody that I think will be better able to answer some of your
I would
challenges.
greatly appreciate that. Thank
Absolutely.
you.
Happy to do that.
Dr. Yip.
I think part of the issue of mental health is we have a big shortage of mental health workers, nurses, social workers. When I was at the Health Professional Education Foundation, we actually reach out and try to give more financial help and scholarship to people who want to be in that field. One of the main factors is that we actually don't have enough people who want or interested in working for mental health. The other thing I'd like to really thank you for the education today, both talk, but I'd like to hear what your work related to what I have been seeing, and I have not seen any progress in the States, is obesity. It's a big issue. I'm a urologist. 30-40% of my patients are Medi-Cal related, and I see all the notes from the primary care. They ask about violence, do you have guns at home, etc. They actually ask about mental health. We do a lot of data collection, but we don't see outcome. And I don't see any improvement in obesity treatment and all that. I'm sure there's some, but I don't see it up.
So obesity treatment is
Or
slightly
education
different.
or
So the
prevention.
issue of obesity is at the heart of chronic diseases in general. It's certainly it's the single greatest risk factor for pretty much every chronic disease that we talk about, and it's based in those social determinants of health. There is nothing medical about obesity and why we have such high rates of obesity. We are making progress in pediatric obesity in California. The rates have improved in not every single county, but virtually every county, and so that's important to recognize. And as far as adult obesity, I agree with you. We're not making progress.
Well, actually, in the past 1 year, I've seen 3 patients, 18 years and younger, weigh 400 pounds.
Yeah.
I was involved
I
because
didn't say
nobody
we'd
can put a
fixed the
catheter in.
problem.
So
I
those are
said we're
pediatric
making progress. And again, my challenge is always we work at a population level as opposed to at an individual level. But we have a Center for Chronic Disease Prevention and Health Promotion that's working actively on obesity. This is always what I hate when government says this, but I sort of have to. We work on what we're funded to work on because there is no general fund available for this problem. But we do have a lot of partnerships, and we are actually doing a lot of work through our WIC program, through our Nutrition Education Obesity Prevention program. I have to say that the bulk of the work that we're doing in obesity prevention is in children, because that's where we've got models that we have seen actually work. But also, we have a pretty active Healthy Communities outreach network where we work with communities on how to improve access to healthy foods and the cost of healthy foods, particularly for the higher risk populations, Latinos and some of the other subgroups populations that have higher rates of obesity. So it's a really difficult national problem.
Right. I compliment your work and the direction. Part of the small clinics and the just a word of my opinion is that I think we do a lot of collection, but as Dr. Bola called me, what is the outcome? How do you measure? What is success? So I think this is the main goal that we need to work on. So
I absolutely agree. I think it's one of the 2 biggest problems we have in public health in California, and quite frankly elsewhere.
Thank you, Dr. Ip. Just an informational item is last year, American Medical Association declared obesity as a disease, not just a condition. So it is important. What it means is that insurance companies have to look at it as a disease. So it's a very big step. So I just want Dr. Ip to know that.
To that point, I will say increasingly in our coalitions, our Healthy Communities coalitions across the state, insurance companies are actually actively participating, and by that I mean they are also contributing funding to the health trusts that communities are using to try to improve conditions across the board. And part of it is that recognition that I think ultimately they will save money as well.
Right. Any public comment? Okay, we have many. Okay. Dr. Lang?
We have a public comment.
Yeah, Dr. Lang.
None on the phone.
Good morning. I'm Dr. Khadijah Lang, president of the Golden State Medical Association, the National Medical Association's California branch, supporting physicians of African descent, representing their concerns and those of the patients they serve. Recognizing the importance of properly controlling patients' pain, this board appropriately made a determination and began requiring all physicians licensed in the state of California to at least acquire a minimum amount of CME regarding how to manage pain and treat it in patients. But recently, Golden State Medical Association has been receiving increasing concerns from our members that their patients in predominantly minority inner city areas
are having problems treating them because their patients are having an inability to fill the prescriptions that these doctors have prescribed them after examining them and following the recommended treatment plans. More and more, especially if these are controlled drugs, particularly I should say if they are controlled drugs, more and more of the pharmacies in these neighborhoods are developing and implementing policies that make it extremely difficult and often impossible for these patients to fill the prescriptions for both acute and chronic pain conditions and syndromes that they are experiencing. Yet, these same doctors have no problem getting the same medications filled for their patients in suburbs and majority areas. Even more concerning is that often they are working with the exact same pharmacy chain, only in a different section of the city. But they'll have different requirements of the physicians submitting the prescriptions and of the patients attempting to pick up the prescriptions by the same chain in different areas of the same city. The result of this is that patients are getting inequity in health care. We feel that the board was 100% correct when a decision was made to require physicians to learn how to and treat patients in pain. These pharmacy policies are creating new and inappropriate barriers to care of these patients and represents further health inequity in populations that are already suffering increased adverse disparities in health care, morbidity, and mortality. Failure to adequately control these patients' pain can sometimes result in them unwisely and unsafely choosing to turn to street drugs after their physicians have prescribed medications that would have been safe. But because they can't get them, feeling they have no other choice to end their suffering, it leads to an increase in addiction for these illegal substances that Dr. Smith is working so hard to help us get control over. It also makes their physicians appear
Lang,
to be
please conclude.
improperly caring for them. So we respectfully request that the board exercise their authority over consumer affairs and look into these concerns to try to see how we can get better access and equity for pain control for patients in inner cities. Thank you.
Thank you, Dr. Lang. Ms. Kirschmeyer will work with the pharmacy board. I think that's where the issue has to be dealt with, but we will follow up. Thank you. Next comment is from Mr. Tim Madden.
Thank you. Tim Madden, I'm here representing the California chapter of the American College of Emergency Physicians, and I just wanted to come up and make a few comments following Dr. Smith's presentation on opioid misuse. And there was a mention from Dr. Berlad about the safe medicine prescribing guidelines that have been largely developed by an emergency physician out of San Diego, Dr. Renee Lev. And she was spearheaded that effort and worked it all the way up the state, where a number of counties throughout the state have all adopted these same guidelines. The impact has been really impressive to the extent that it's really changing behavior of what we see as the frequent flyers coming into the emergency department, either seeking opioids for themselves, for their own issues, or drug seekers finding it to try and get prescriptions to sell on the streets. And once we're seeing the hospitals all get on the same page, treating these individuals the same, the behavior has really changed markedly. These are guidelines that our association promotes, as well as the California Medical Association, the California Hospital Association, and the Emergency Nurses Association. And as Ms. Kirschmeyer mentioned, the medical board has been very helpful in getting those over to the Department of Public Health as being a part of their program. To the extent that we can participate with the Department of Public Health, we're more open to doing that and fitting in and trying to stop this progression wherever we can. Thank you.
Thank you, Mr. Madden. Any other comments from the audience? Comments on the phone?
Do we have any comments on the line?
Comments on the phone.
Thank you. Dr. Smith, thank you again, and I can assure you from this board that will be your true partners in both of them, that is opioid epidemic and also social determinants of health. So Please feel free to work with Ms. Kirschmeyer and the rest of the board anytime you feel. Thank you. The next item is item 17, presentation on the board's demographic study by the California Research Bureau. Here to make the presentation is Mr. Patrick Rogers, a senior policy analyst with the Bureau. While Mr. Rogers comes forward, I would like to take a moment to thank the Bureau for conducting this study for the board. As members remember, this independent study was requested by the medical board after the concerns were brought to the board's attention. We know it took a lot of time and analysis, and we appreciate the Bureau for performing the study. Mr. Rogers.
Good morning, Mr. President, Dr. Gnanadev, and members of the board. Thank you for the opportunity to talk with you today. My purpose today is to present the California Research Bureau's findings of our review of the demographic characteristics of physicians disciplined by the board. As the board is aware, the impetus for this study comes from the concerns of BAPAC, the Black American Political Association of California, and GSMA, the Golden State Medical Association, about the perception of disparities in how the Medical Board of California disciplines physicians. They have argued that the medical board disciplines minority, particularly African American physicians, more often and more severely compared with their white colleagues. In December of 2015, the Research Bureau met with representatives of BAPAC and GSMA to hear their concerns in more detail. Following that meeting, the Research Bureau developed a list of potential research questions to pursue, from which 5 primary questions were selected based on their overall importance and their feasibility given the time, data, and resources available. They were, first, how is the likelihood of a physician having a complaint made against them correlated with the race or ethnicity of the physician? 2, how is the likelihood of the medical board dismissing versus escalating a complaint to a disciplinary hearing correlated with the race or ethnicity of the physician? 3, how is the severity of the medical board's disciplinary action against a physician correlated with the race or ethnicity of the physician? 4, does the correlation between disciplinary outcomes and the race or ethnicity of the physician vary across different tenures of medical board executive directors? And 5, does the correlation between disciplinary outcomes and the race or ethnicity of physicians vary whether the medical board's Panel A or Panel B reviews the investigation? So for this study, the California Research Bureau used data supplied by the Medical Board of California on complaints, investigations, and discipline that were drawn from an archival data set created by the board during its transition to the BREEZE record system in 2013. The archive data covers July 2003 through June 2013. Physician-level data were drawn from a similarly archived data set created of all active physicians as of June 2013. Physician demographics were drawn from responses to a voluntary survey that the medical board sends to physicians when they renew their licenses. As part of that survey, physicians are asked to provide their ethnic background across 25 potential categories and are able to select more than one. They also have an option to decline to state. These survey responses were used to identify the race for all responding physicians. The Research Bureau began by first identifying non-responders. Of the 125,000 active physicians included in the study population, 25,000 did not provide data on their ethnicity. In some cases, the question was left blank. In other cases, the respondent checked the box marked decline to state. This represents a response rate of 79.98% of all physicians in the study. This is fractionally beyond the threshold for which the Office of Management and Budget recommends testing for non-response bias. In order to test for that, we conducted 2 analyses. First, we benchmarked survey respondents against the expected number of physicians as estimated by the U.S. Census using the American Community Survey. In general, the distributions were in close alignment. However, there are 2 exceptions, one for Latino physicians and one for physicians who responded other. One explanation for this could be differences in question wording. The census asked 2 separate questions, one about Hispanic, Latino, or Spanish origin, and a second about the respondent's race. The medical board's survey asks a single question about ethnic background and combines Hispanic, Latino, or Spanish origin with both race and other national origins. Such differences could result in the same person responding differently to the two surveys. However, we cannot be sure of the actual cause of the discrepancy. As a result, we do recommend caution in interpreting all the subsequent results, particularly regarding Latino physicians. To further assess bias, the Research Bureau also evaluated whether there were differences between how survey respondents and non-respondents regarding their likelihood of receiving a complaint. We found a small but statistically significant difference between the groups. It appears that non-response bias was present in the data and that there are differences in the likelihood of complaints for responding versus non-responding physicians. However, the effect is quite small and does not appear to be correlated with race ethnicity, with the exception of Latinos. We also urge anyone interpreting the result of the study to be aware of other limitations. Although the study started with a large overall sample, complaints, investigations, and discipline are each rare events. As a result, out of the 125,000 physicians we started with, only 1,223 could be identified as having been disciplined a total of 1,267 times during the study period. This created issues with small sample sizes for some of the statistical tests. Additionally, this is an observational study. The best this review can show is statistical association, not cause and effect. Finally, a number of important variables could not be included, including measures of physician quality and patient characteristics, both of which represent important intervening factors. This further limits Research Bureau's ability to draw robust conclusions, as there are other reasonable explanations for the patterns observed. In order to evaluate the relationship between physician race and disciplinary outcomes, the Research Bureau conducted two sets of tests for each step in the disciplinary process: complaints, investigations, and discipline. The medical board reviews complaints submitted for a number of physician violations, including substandard care, prescribing issues, billing issues, sexual misconduct, impairment, unlicensed practice, unprofessional conduct, and other practice issues. More than 4/5 of physicians did not receive a complaint during the study period. An examination of the complaints using a chi-square test of independence showed that there was a relationship between physicians' race and the rate of receiving a complaint, and that the correlation was unlikely to be random chance. To provide further detail, the Research Bureau conducted a multivariate logistic regression and calculated odds ratios for key variables of interest. In addition to race indicators, the regression controls for physician age, sex, board certification, training status, hours reported spent on patient care, research, teaching, and administration, and other, and demographic characteristics of the county of practice were included. After controlling for those intervening factors, physicians identifying as Black or Latino showed an increased likelihood of receiving a complaint. On average, holding other controls constant, the odds of a complaint being made against a Latino physician were 1.1 times more likely than for white physicians. Likewise, a Black physician was 1.4 times more likely to receive a complaint. Asian, Native Hawaiian Pacific Islander, and non-responding physicians were all less likely to receive a complaint compared to white physicians, while Native American, other, and physicians identifying with two or more races did not show a significant result. Once a complaint has been made to the medical board, its central complaint unit evaluates the details of the complaint and determines whether an investigation is required. Out of 32,978 complaints, 7,731 resulting in an investigation. This represents 23.4%. The majority were dismissed, referred for mediation, or were minor violations that resulted in a fine. An examination of the complaints data using a chi-square test of independence showed that the relationship, again, between a physician's race and the rate of complaint dismissal were correlated, and the correlation was unlikely to be due to random chance. As with the analysis of physicians to complaints, the Research Bureau conducted a multivariate logistic regression and calculated odds ratios for key variables of interest. After controlling for intervening factors, physicians identifying as Latino or Black continued to show an increased likelihood of a complaint escalating to an investigation. On average, holding other controls constant, a complaint made against a Latino physician was 1.3 times more likely to escalate to an investigation than ones against white physicians. Likewise, a complaint made against a Black physician was 1.2 times more likely to escalate to investigation. Asian physicians and decline to state were the only group showing a clear reduced likelihood of a complaint escalating to an investigation. Native American, Native Hawaiian, Pacific Islander, other, and two or more races did not show a statistically significant relationship. Once a complaint has been referred for investigation, the complaint is assigned to an investigator within one of the medical board's district offices or to a medical expert in the case of a quality of care complaint, as well as to a deputy attorney general. Investigation may be closed without charges if the violation cannot be confirmed or if there is insufficient evidence to take disciplinary action. The decision about whether to draft formal charges is held by the Deputy Attorney General. If the Office of the Attorney General files charges, physicians typically either agree to a stipulated settlement, i.e. a plea bargain, or contest the charges. In these cases, an administrative law judge drafts a recommended decision which is then subject to final approval from a medical board disciplinary panel. Each case is assigned to one of two panels, either Panel A or Panel B, based off the first initial of the physician's last name. The likelihood of the medical board disciplining a physician is generally low. Out of the 7,731 investigations included in the study, only 1,267, or 16.4%, resulted in discipline. When the Research Bureau examined disciplinary outcomes using a chi-square test of independence, the relationship between a physician's race and disciplinary outcome were again found to be correlated, and the correlation was unlikely due to random chance. And as in the prior sections, the Research Bureau conducted a multivariate logistic regression, calculated the odds ratios for key variables of interest. The first part of this analysis closely mirrors that used for complaints and investigations. However, for this step, we included a second model specification that looks for differences between the tenures of the 5 executive directors that served between July 2003 and June 2013, as well as differences between the 2 panels that review disciplinary recommendations. Latino physicians, again, showed an increased likelihood of an investigation resulting in discipline. On average, holding other controls constant, investigations made into complaints against Latino physicians were 1.6 times as likely to result in discipline as ones against white physicians, who are used as the reference category. No other groups were significantly more or less likely to have investigations result in discipline. The Research Bureau also looked at whether the likelihood of discipline was related to the executive director's tenure and the race ethnicity of the physician at the same time. Likewise, the Bureau evaluated the likelihood of discipline given both the disciplinary panel and the race ethnicity of the physician. These are referred to as interaction effects. Controlling for other characteristics, the analysis was unable to identify an effect on either directorship or panel selection for minority physicians. In summary, the impetus for this research was a concern from stakeholders that minority physicians, especially black physicians, are disciplined more often than their white colleagues. The analysis focused on evidence of disparate outcomes for minority physicians at the level of complaints made, investigations conducted, and disciplinary decisions. Returning to the 5 research questions we were asked to review and emphasizing the necessary caution in drawing conclusions or assigning a cause to these patterns, we found 1. A higher likelihood for Latino and black physicians to have received a complaint compared to their white colleagues. Latino and black physicians also had a higher likelihood of those complaints escalating to an investigation, and Latino physicians also had a higher likelihood of investigations resulting in discipline. The different tenures of medical board executive directors were not correlated with the likelihood of minority physicians receiving discipline, and likewise, the panel assignment was not correlated with the likelihood of minority physicians receiving discipline. While the data do show evidence of disparate impacts on the basis of race, due to the nature and limitations of the study, the Research Bureau, however, cannot conclude the medical board is engaging in discrimination. Now, I can now answer any questions that you have.
Thank you, Mr. Rogers. As you mentioned, this is an observational study, so thank you for doing all the work. Questions? Dr. Cross.
I have so much to say, I actually had to take notes. In my opinion, the board owes thanks to the late Dr. Anthony Jackson for having brought our board to the realization that discrimination should never be assumed to be absent from our process, but rather we must always be vigilant to prevent discrimination. I believe the medical board deserves credit for launching its own preliminary analysis, but deserves greater credit for having requested an outside independent data analysis by the California Research Bureau. Certainly, the medical board owes you a great debt of thanks and your colleagues for the very difficult and time-consuming work that you've done. I think it's important for the public to be reminded that the medical board is driven by consumer complaint. It may be worthwhile to analyze sources of racial and ethnic disparities in complaint rates. The public must also be reminded that the CRB analysis studied disparity, and disparity if it exists, does not ipso facto mean that discrimination is the source of disparity. While the CRB analysis does not prove discrimination, we must be mindful that neither does it prove that there is no discrimination. Purposeful anti-discrimination activity requires much more than the board making a policy statement. We should assume that there may always be discrimination, and therefore we must endeavor to find it, stop it, and prevent it in an ongoing manner. I am pleased that the medical board president will appoint a task force, but I am hopeful that we may find benefit after we hear the work of the task force in perhaps establishing a standing anti-discrimination committee. While the data analysis covers the time period 2003 to 2013, and we can't necessarily be responsible for what has occurred in that era, I'm hopeful that there is no discrimination in the process at this time, but I take very seriously that it's our obligation to find it, stop it, and prevent it, and I think that has to be in an ongoing fashion. Thank you, Mr. Rogers.
Thank you. Any other comments from the board? Yes, Dr. Hawkins.
Thank you very much, Dr. Kraus. I appreciate and support your comments. Just a couple of questions. How significant is the failure to identify themselves as a race or not? How significant is that, where the person declines to state their ethnicity or race? And although not really sure, I really wonder, and I think you actually pointed to the fact that when we think about Latino, when we think about Mexican Americans trained in the U.S., when we think about individuals from other countries, South America, for example, how does that figure into these numbers? And just finally, do we know did you study whether the person had counsel impacted on discipline?
So the last question, no, we were not able to look at whether they had counsel. That's actually one of the critical and intervening factors that I was concerned about, but I was not able to get adequate data about whether or not they had counsel. Part of there too is that there's a multi-step process, and so if they have, you need to know when they have it, not just if they had it at some point. So unfortunately, we were not able to control for that. In terms of the question of self-reporting, that is also one of the limiting factors. That we don't know for what reason somebody might decide to decline to state versus to not versus to respond. We did check to see if there was a difference between the overall breakdown of physician demographics from the board data compared to the American Community Survey. One of the advantages that they have is that they're fairly aggressive about getting responses, and so we can assume that they have a higher response rate than the medical board is going to get. And we did not see strong differences between the two surveys, with the exception of Latino physicians and other physicians. We also checked to see if non-responding physicians were different in the rate of complaint compared to responding physicians, and they were, but the difference was small. It was small, but it was statistically significant.
Ms. Pines.
So I want to thank Kim and our team, because I remember some years ago this came to our attention and they didn't ignore it. And I'm glad that when our analysis didn't really demonstrate that there was a particular issue, that we were still willing to go the next step and reach out to your team. So the report demonstrates or shows that there is disparities, but not exactly what's causing the disparities.
Correct.
And when I heard you talk about this report, I also heard multi-departmental potential causes or links to. So potentially us, potentially the DAGs, potentially the judges. I know that we have diversity, well, not diversity, but sexual harassment training, and there's some diversity training inside of that, and I wanted to see if, Kim, do we have any diversity training that we do with the staff?
So right now, every 2 years, all staff is required to take the sexual harassment training, sexual harassment prevention training, I should say. And it's actually, when they take that, part of that is looking at protected classes. So it does go through that. So it talks to it during the training, but because of Mr. Patrick's report, and we've been in contact with Mr. Rogers, and so we've been in contact with him, and so knowing that this was coming forward, I actually reached out to the Department of Consumer Affairs, because one of the things is they're training out there because of the multifaceted approach that, there's multiple entities, including the experts, when they get a case and when they review it and opine on it. What we want to do, and I've talked with Ms. Lawley, is get with Solid, who's the DCA training group, and identify some experts. And I actually think that they actually have a couple individuals that work for them that actually have diversity training, because it needs to be more in depth than that, because we have to be proactive about it. And so although there's no findings in it, the reasons for the disparity, we need to go that extra step. So everybody, in my opinion, if the board agrees, in my opinion, everybody from the start of, the complaint coming in the door, although we can't control complaints that are received, that's outside of our control, external to us, but from the time the complaint's received, so all of the analysts that handle it, all of the individuals who review it, next step investigators, the deputies, all the way through the staff, then that go through the next step of it, and then all the way to the board members. That training should cover that broad sense of everyone. So I think we need to actually develop a training, and there might be something out there. I haven't had the chance to really go look and see what all is out there, but if not, we need to have it developed, and Solid can do that. The one thing we'll need to do is, because we have probably close to 1,500 experts that review our cases, we would want to have something that could be a online training that they would be able, and as well as for board members, we'd want to be able to send it out and make sure that they're taking it to where, as they go through, there's the clicking of the button to make sure it's actually been read and have gone through, kind of like the training that's required now. They have those steps to make sure the individuals can't just click through it. So we want to make sure that we develop something that's pertinent to staff and everyone else along the process.
Dr. Yip.
Is it going to be a one-time study, or we have prospective, concurrent, looking at, cooperate with our staff and you? Hopefully we have a report once a year or once every 2 years, how to refine it by insurance type, language of the patients, count, etc.?
Actually, I'll announce the task force. We got multiple tasks for the task force. It will be our job, not his. So. Yes, Dr. Boland.
Thank you very much. This was really very enlightening information, but I want to kind of go back. I'm not sure if this was Dr. Hawkins' question, but because there are so few Latin American and African American physicians in the California pipeline as it is, can you break out for us the data that shows us for the international as well as the USIMG, and does training make a difference? Because our academic centers in many places, our workplaces, are looking at about cultures of inclusiveness and diversity, and the fact that we are having to be and needing to have inclusiveness and diversity as part of what we do and how we think and how we retrain our physicians. I'm just curious if where they trained has an impact.
So I looked at training status, whether they were currently a resident or not, whether they were currently a fellow, and the years of postgraduate training that they had. We looked at whether they were in-state or out-of-state physicians, and then we were not able to look at like the quality of the institution. But I didn't have data on every physician on whether they were international or domestic, but there was a limited set for which I was able to get data on that, and when I ran that, it made no difference. And by that I mean it did not change the racial. It did not affect the race was not correlated with that.
Ms. Willis, go ahead, please.
I also had a question about whether there was information about identifiable surnames that you looked at.
We did not have anything like that.
Okay. Is that something that's accessible to you?
So we had names. I'm pretty sure I know for at least some of the data sets there were names included, but I did not attempt to do things like identify the name and from that kind of try and intuit the race of the physician. The most I probably would be willing to do with that would be to do something along the lines of do it as a data check against the survey response on the race ethnicity question. Since they were responding, we thought that was a better measure, and I didn't want to try and combine the two responses into some kind of aggregate measure of ethnicity because that would add a lot of error to our variable.
Dr. Cross and then...
Oh, sorry.
Mr. Rogers, I also appreciate and want to reiterate that in your report and spoken comments, you recommended caution in interpreting the results and jumping to conclusions. And I also want to reemphasize to the public that 25,000 of the physicians that are included in the study practice outside the state of California. And the medical board is somewhat limited in analyzing the processes that occur in other states, and we take the conclusion of actions in other states to be factual, and in many cases we take actions based on processes that have occurred outside the state of California. I also want the public to remember, as you stated, that 20% of physicians have failed to identify with a particular racial or ethnic categorization. It was interesting to see in the statistical analysis that the non-responders had lower rates of complaints, lower rates of investigations, and lower rates of discipline. So I wonder if we'll ever know why that is. But I think that to whatever extent the medical board can encourage licensed physicians to be more accurate in their own data reporting, that will also help us in ongoing analysis of data prospectively.
Ms. Pines and then Mr. Warman.
I was just going to say that, typically when we get to a point of having to do a study or an analysis, that it has impacted people. And in this case, it has impacted some people who came to us. So one of the recommendations I like to make is that we have a meeting where we listen to what those challenges have been so that we can sort of just get to the discovery of where the problems may lie. So I like to, as part of the task force, that we have a listening opportunity to include those parties.
Right.
Okay.
Mr. Warman. Dr. Bishop.
I'm mindful of the fact that the complaints are the source of all the data. And do we know anything about the nature of the complaints and or the, quote, egregiousness or the source? Again, that might make a huge difference as we've talked about, as Dr. Krause has talked about. Some of these are coming from other states, but if the sources of the complaints are, for example, 805 report or another state, or is it anonymous, or is it from a hospital, or that might help us to determine again if this, because it seems like it starts off initially with some differences right at the bat. And would you have the ability to massage this data anymore to look at the complaints themselves? See if there's any differences in, again, the source and the nature / egregiousness of what is complained about. I can imagine if someone is complaining that someone was rude to them versus 805 report because of 3 patient deaths, to see if, again, there's any disparity from that standpoint.
So there was a variable included in the data that I received on the complaints that looked at the type of complaint. And I was able to look at, include those as controls in some of the models that I ran. That I don't believe I had information on whether it was a hospital, coming from a hospital, or who was the complainee, or complainor. but I was able to look at the type of complaint. So was it a quality of care complaint? Was it a billing issue? That sort of thing. And many of those were significant, but they did not affect the coefficients for the race questions.
Yeah, Dr. Levine.
Thank you so much. This is obviously incredibly detailed work, and I think we really appreciate it. Given your comments about the issue of small numbers, can you project how long a period of time we'd need to mitigate that issue, to actually to get enough data to draw conclusions? And is it such a long period of time that it would begin to raise questions about the validity, if you will, of making assumptions, say, over a 20-year period?
Yeah. I haven't done a power analysis. Was what you're looking for? Is essentially, can we answer this question? How much data? How many observations do we need? I have not done that. Looking at the number of potential confounds that I can think of just off the top of my head in terms of things that would affect the likelihood of getting a complaint, of an investigation being triggered, and that investigation resulting in discipline, the number is going to be very large, particularly considering, starting from the number of physicians. By the time you get to how many physicians are disciplined, the numbers are very small. I think an observational study probably would be unfeasible there. And you would probably need to do something more along the lines of an actual experimental approach to actually get an answer. I don't know whether that's even possible, given the fact that these are practicing physicians, and there's only so much work you can have them do for you. So I think that's unfortunately where we're at.
Thank you.
Thank you, Mr. Rogers. Even though it's observational study, even though we can't conclude anything from it, I think this board takes it very seriously. Let me put it that way. I just want everybody to know this is the board. This board is the one which asked for this study. And you can look at this board. This is very diverse group of board members. So after looking at the entire thing, what I wanted to do was create a task force. And the task force, they can review the existing complaint, investigation, and disciplinary process to better understand the institutional and procedural issues. They will also meet with the stakeholders like Ms. Pines recommended. Ms. Kirschmeyer, Ms. Pines, and I spent quite a bit of time on this one. Ms. Kirschmeyer is the executive director, and Ms. Pines is my vice president. So I decided to have two task force members. One is Dr. Krause, who has been working with you on the indicators, and Ms. Jamie Wright. Ms. Wright has contacts with the community, and she volunteered to be on. So I would recommend this. I would create this task force, and they will do the work, including working with the stakeholders and looking at this complex process. Don't forget that this process involves everything from the number of complaints to the consultants who review the complaints to the Attorney General's office and the investigators from the Department of Consumer Affairs. So it's not medical board itself. It's a fairly detailed, complicated process. We want to look into and really see if there is even a remote possibility of anything related to race, where they went to school, whatever it is. So we don't want that come into play. This board's job is to protect the consumers, period. So that's what we'll do. Any comments from board members? Okay. Public comment. I have two. Dr. Lang.
Your mic's not on. Yeah, if it turns green, you're
okay. Thank you. Good morning again. This is still Dr. Khadijah Lang for Golden State Medical Association. And I would like, on behalf of the local societies in California that I represent, as well as all of our members, I would like to first and foremost say thank you to Ms. Kirschmeyer and to this medical board, because we really feel that the fact that you listened when we came forward with these complaints, with these concerns rather, the fact that you actually listened to what we were saying was something that was very positive, that gave us encouragement to continue trying to establish communication and help get you better informed about what's actually happening with the troops on the ground. So we have a strong desire to say thank you for launching this study. I would also like to say that the study has now been completed. For me, I'm not a statistician, but what I heard was that it does bear out and confirm our initially stated positions that there are some increased things going on against physicians that are African American and Latino. And I think it's really important for the board to remember, since you are protectors of the consumers, that the average African American physician has 3.5 to 5,000 patients per physician, as compared to the average white physician that has 1,000 to maximum 2,000 patients per physician. So whenever a physician that's African American is removed from a community for a non-patient compromising issue or offense, you're impacting significantly a much larger number of patients that are depending on these physicians in areas that are already doctor deserts. I think it's really important for us to look, because of that disparity, it's important for us to look further. I agree 100%. I appreciate Ms. Pine's recommendations that we look further to find out what are the etiologies of this and what can we do to decrease that. But because even a difference of 1.4 or 1.2, that's significant. 1.4 is 40% increase, and that is significant. So I think it's really wonderful that you guys are already moving forward with the next step and planning to look further and see how we can prevent this from continuing to happen so that our patients can have better care, and our physicians, who have actually been funded and supported by public dollars as they go through residency training, all of them are supported by Medicare dollars. I think it's important that we not lose these physicians who have so much invested, so much knowledge that they are trying to give back to the community. So we at Golden State are ready to help you and support you if there's any information you need from us that can help look at differences that might be impacting that. Bear in mind that the average, that it's already documented, that African American physicians as a whole are making less money than Caucasian physicians, and therefore the profit margin is smaller. And so once we have an increased accusation rate, it's going to be harder for the black doctor to defend themselves because they don't have as much money to hire legal counsel and therefore be able to go through the process and withstand the constraints and limits that are put on them during that time period. So I would also ask that you bear those things in mind as you go through your further evaluation. Thank you.
Thank you, Dr. Lang. And as I mentioned before, the social determinants of health, it applies to doctors too. Mm-hmm. When the doctor practices in a poorer neighborhood, they cannot hire appropriate consultants, appropriate attorneys. We know that. The task force will look into almost everything. Thank you. Next one is Julie D'Angelo-Felmeth.
Good morning. Excuse me. Julie D'Angelo-Felmeth from the Center for Public Interest Law. I first want to say that I don't disagree with anything anybody here has said today. I just wanted to give you some information. As some of you know, I served as the Medical Board Enforcement Monitor from 2003 to 2005. And I have some comments based on what Dr. Bishop said and Dr. Krause said. My appointment in 2003 followed closely after the legislature enacted in 2002 some priority enforcement areas. This is in Business and Professions Code section 2220.05, I believe. These are types of complaints that the board is expected to give priority attention to. one of the things that I was required to do as enforcement monitor was to look at the nature or the source of complaints or reports that most reliably lead to medical board disciplinary action in these priority areas. And I did that. And I found that mandated reports, particularly Section 805 reports of hospital disciplinary action, and at that time it was 801 reports of medical malpractice payouts, much more reliably led to medical board disciplinary action than did consumer complaints. In fact, the vast majority of consumer complaints are closed without formal investigation of any kind. So I did that, and that's what I found, but my study was done at a very early time after those enforcement priority areas were enacted. And I think that it might be time to revisit that issue or that mandate. You have 12 more years of enforcement data under your belt since I was required to do that study. And this might be an appropriate issue for the task force to look into in terms of the findings of the California Research Bureau study. Thank you.
Thank you, Julie. Next is Dr. Sawaj.
Thank you for allowing me to speak here today. I'm Dr. Savage, and I'm an associate with Dr. Jackson on this project, and it's a great loss for his passing. And actually, he and I have talked about this a great number of times. There's a term that he likes to use is unconscious bias. I think, I appreciate the statements all the commenters have made, and I think they're very right on spot. But my fear now is we're going to get into studying too much of nuances that are not very important but factual. It's well known that in certain societies like our country, there's an unconscious bias, particularly with African Americans. We have unconscious bias on everything, but particularly with the situation with African Americans and to a lesser degree, the Hispanic population. And that should be considered. Someone mentioned creating some sort of a training program, I believe, as in the kind of anti-sexual harassment process. Well, that's probably need to be done in this setting of making people aware of their unconscious bias. There are many, many studies have pointed to this fact. And one notable one, I'm going to take a few more minutes, is that in 2000, there's an article in New England Journal of Medicine talking about cardiologists treating various ethnic groups and socioeconomic status people. These were all actors. They were matched for economic value, for their physical appearance, etc. And it just turns out that the more African American type folks, the poorer people, got less treatment. These are on the clinical. These were like academics saying what if clinical trials, a clinical test. And they just got less studies, less treatment. And was when they were, unfortunately, the few African Americans and Latinos in that group fell in the same category, gave less services to less stereotypical negative people. So, unfortunately, when asked why this happened, they said, "Well, I didn't think I didn't think that they would understand. I didn't think they would be compliant. I thought that they thought they were lingering." So these are unconscious biases that we need to get in contact with, and I think we should probably spend, if there were folks back home, if I had my way, we spend more time in training people about the unconscious bias and the frequency and the prevalence of this process, how it affects our day-to-day interaction on this process. And again, Dr. Jackson is the inspiration for this whole program. And his loss is really, really lost. His wife had planned to come today, but it became a bit more heavy emotional burden on her. She couldn't come. So I apologize for her. And she asked me to bring back a good report. I based the report. The report was a very good report. I think it covered a lot of territory. Some things were amiss. Certain interpretations can be interpreted. The one thing I ever thought was, I called it delusional effect. Bringing people from outside the state in terms of the physicians sort of diluted the effect that California itself had, which we were more concerned about. It may have made it a positive or a negative. We don't know what that effect is, but nevertheless, that should be considered. Okay. Thank you.
Thank you, Dr. Savage. Please convey our condolences to Mrs. Jackson. Next one is Yvonne Chung, CMA.
Good morning, Yvonne Chung with the California Medical Association. We would like to thank the board and CRB for completing this important study. CMA represents over 43,000 physicians, and we really recognize the need to do whatever we can to maintain a diverse physician workforce that represents the patients of this state. We do appreciate that the board is taking additional steps to continue to study this issue and that you haven't stopped with the completion of this report. A few thoughts. We hope that the ongoing work will include follow-up studies to continue to track this data, that we can track the progress and whether a change occurs over time. In addition, the board may wish to consider revising the survey, and we would very much be interested in being part of that as well if we are not collecting the data that we need to be collecting, or even doing a post-survey, a separate survey for physicians who have gone through the disciplinary process and try to collect some additional information about their experience. And we look forward to working with the board on this. Thank you.
Thank you, Yvonne. Any other comments from the audience? Comments on the phone?
Comments on the phone.
Okay, thank you. So the task force, we gave what they need to do, but the timeline report should be here by the next meeting. So that's what we expect, and I talked to both the members. They are willing to put the time. Let me put it that way. It takes a lot of time. So it's thank you for volunteering. I truly appreciate it. Okay, then we'll go to agenda item 26. Jennifer, this is what Kim has, so I can't help you. That's the Enforcement Committee report. Dr. Yip.
Thank you. The Enforcement Committee met yesterday. The Chief of Enforcement, Ms. Delp, advised that the board has provided Officer Administrative Hearing with 6 training sessions, and on February 8th, she and Executive Director, Ms. Chris Meyer, will be meeting with executives from the Office of Administrative Hearing to discuss further training and other enforcement-related matters, such as recently adopted manual model of discipline orders and disciplinary guidelines, which took effect January 5, 2017. Ms. Delp also reported that the Central Complaint Unit is in compliance with Business and Professional Code Section 129 regarding case initiation timeframes. Staff is currently opening cases within 6 days of receiving a complaint. On January 4, 2017, met with the board staff to review the Central Complaint Unit's closing letters. During the discussion of the Sunset Report at the October board meeting, board members comment that the closing letters need improvement. The meeting was very productive and revised the letters. Ms. Delp also advised that she will be meeting with managers to hear their suggestions about ways to modify processing methods to improve the way enforcement business is being conducted, with a goal of reducing timeframes and improving customer satisfaction and patient protection. Ms. Romero gave an informative overview of the Central Complaint Unit's function regarding the handling of consumer complaints, and Ms. Delp also gave an update regarding the metrics being used to monitor the probation unit's performance with addressing violations of probation. She also reported the probation is meeting the goals set by the management. Ms. Delp also gave an update regarding the efforts being made to recruit expert reviewers and provide them with training. Committee members are concerned about the compensation rates being given to experts to assist with the case investigations. Ms. Kurtmeier commented that the board did increase the overall budget of the program. She also stated in March the board can pursue further requests to increase compensation for the expert reviewer. They also suggested we may consider giving differential pay to different categories of experts. Ms. Kurtmeier also advised as incentive to attend the training. The experts are receiving CME credits now. Committee members, no further agenda items, and Ms. Delp state at future committee meetings there will be update to the interim suspension order project and an update regarding the prohibited practice condition of probation. That concludes my report. Thank you.
Thank you, Dr. Epi. Any questions? Any comments from the public? Any comments on the phone?
No comments on the phone.
Thank you, and I'm seeing a little agitation on my board here, so we'll take a 5-minute break. Okay, good afternoon. We're back. The next item is agenda item 18, discussion and possible action on the legislation and regulations. Ms. Simos.
Thank you. If you turn to tab 18 in your packets, the first thing you'll find is the legislative calendar and the deadlines, and this is just to give you an idea of some of the deadlines coming up. One important one is February 17th is the last day for bills to be introduced. So although we only have one bill today, there'll be many more at our next board meeting. And the other thing I wanted to let members know about is that Assembly Business and Professions Committee has appointed all of its members, and there's almost half are new members. So Kim and I will make every effort to visit those members and to brief them on the board and the upcoming sunset. And in Senate Business Professions and Economic Development, they have 4 new members, which is almost half of their committee. As Dr. Ganadev reported, our sunset hearing will be at the end of February, on February 27th. So Dr. Ganadev and Ms. Pines will be there to testify. So I did not include a tracker list because we only have one bill this time, and that's AB 40. So I'm just going to go over this bill and my recommendation. So this bill would allow authorized health information technology systems to integrate with and automatically query the CURE system on behalf of an authorized healthcare practitioner. And really the purpose of this is, especially for emergency departments, for those systems to help make it more efficient for the users. And there's some built-in protections here to make sure it's an authorized user. This bill is simply a vehicle for the systems to talk. It doesn't negate the requirements that a physician look up use cures as required in SB 482 when that becomes effective. I can go through more details if you want, but really the purpose of it is just to make it more efficient. We've always believed that cures is very important. Anything that would make it more efficient, as long as it includes the correct protections to make sure that the 482 requirements can be met. So board staff is suggesting that the board support this bill, and I believe the sponsor is also here to talk.
I move to support that AB 40.
Second.
Okay, any discussion? Who is here?
Mr. Madden is here representing the sponsors.
Emergency physicians.
Okay. It's fine, I think, unless there is a discussion. So, anything else?
It's good. It's a good.
Okay.
It's a good bill. Necessary.
Any public comment? Any comments on the phone?
He's coming.
Oh, come on. Oh, I do have it here.
Thank you. Tim Madden, once again representing the California chapter of the American College of Emergency Physicians. As Ms. Simos mentioned, we are the sponsor of this bill. We agree with her write-up and her analysis and her recommendation and the comments from the board. We think this is an important step to encourage the further use of cures, and it integrates into the health information system, so it makes it a little bit more automatic. And we encourage the board to support the bill and available for any questions. Thank you.
Thank you, Mr. Madden. Next is Yvonne Chen.
Good morning, Yvonne Chung with the California Medical Association. We don't have any issues with the staff analysis because we do believe there would be great value in having electronic health information technology communicate with cures, and that it, if done right, would improve physician workflow. However, CMA does want to ensure that when it's done, that it's flexible enough to accommodate many different types of systems that physicians use. For example, it would be very problematic if a legal structure is established that gives DOJ the ability to shape the HIT landscape by choosing only a handful of vendors to work with. We believe that the language as drafted would do this. We're currently working with the author and the sponsors on this. We believe we also need to be clear about how we consider how this interfaces with the SB 482 requirements. We have some concerns that, as drafted, it might not meet the needs of most physicians and may put physicians at risk of being out of compliance with SB 482. So we continue to work with the author and the sponsor, and we would encourage the board to take a neutral position on this bill until we can resolve some of these issues. Thank you.
Sure, you got.
Thank you. I don't understand. I don't understand what your concern is.
I think, so my understanding, I'm not the HIT person in our office, but my understanding is that we wanted to make sure that there was enough flexibility in the language that it wouldn't, that the interfaces wouldn't be limited to certain kinds of vendors on the HIT side. Yeah.
There's a number of different systems, Epic, Cerner, and others that are used in the medical field. I presume that's what we're talking about.
Yeah, so it's really it's a technical issue. We have no
yeah, we'd want to ensure
quarrel
that
with
whatever
the
system
concept.
is,
It's just how
it
it's
has equal
done.
access by
Yeah.
all these vendors, so you wouldn't preferentially allow only 2 out of 6, for example.
Right,
So
but
be an
it's a
assistance.
little hard to predict how that would work out. So we just want to make sure
Is
the
that an
language is
accurate
flexible
assessment?
enough. Yeah.
Jennifer, do we have anything to do with this?
So in looking at the actual language in the bill, it defines a health information technology system in the bill, and it's a pretty broad definition. So, I mean, to me, I'm not a health information technology expert, but the definition in the bill doesn't look like it's narrowing it to certain systems. It basically says an information processing application using hardware and software for the storage, retrieval, sharing of, or use of patient data for the communication, decision-making, coordination of care, or the quality, safety, or efficiency of the practice of medicine or delivery of healthcare services, including but not limited to electronic medical record application, health information exchange systems, or other interoperable clinical or healthcare information system. So to me, that's pretty broad, and that's how they're defining. It has to meet certain requirements, and those are the requirements to include the protection. So the user has to be authorized. There has to be a trail to make sure that to follow that authorized user. That doesn't mean that the 482 requirements aren't still in there. So when they become operable, that physician will, if we were to get a complaint that the physician didn't check cures, that physician will have to prove that they checked cures before they saw that patient. And this system allows them to do this. Now, this bill doesn't say the person checking cures has to be seeing that patient, but SB 482 requires that. So this bill doesn't negate that. It just is an avenue for the health information. This is more like the avenue for the systems to talk to each other. It doesn't also include the same requirements as 482, but it's different bills. It's really for the systems to talk with cures.
Dr. Lewis.
Okay, so you're saying that if AB 40 and DOJ decide not to support a certain technology system like Cerner's inpatient and Epic is outpatient, the 482 will supersede all that, and the AB 40 may not apply to that technology
What I'm saying is,
system.
SB 482 still applies. Those requirements in SB 482 still apply. It's kind of, it's interrelated, but it's two separate issues. This is allowing those systems to talk, but the requirements in SB 42 are still there. So the physician still has to meet those requirements, regardless if his or her health information technology system talks to cures or not. So to me, I was looking at it a little bit as two separate issues. This requirement applies, and this allows systems to talk to each other. This provides a mechanism for a physician to prove that they check cures because of and I don't know if maybe Mr. Madden wants to speak on the behalf of the sponsor, but that's how I looked at it as I was analyzing it. I'm not an expert, like I said, in health information technology, but this definition looked pretty broad to me and not to narrow it to certain systems.
Once the bill, if the bill is passed or becomes a law, all the implementation is by the AG's office, nothing to do with the medical board?
Well, the AG's DOJ does oversees the cure system.
It's
so
a
this
bad
sets,
thing, but yes.
Yeah, so this sets
it should have
forth
been under medical board, but go ahead.
So this sets forth certain requirements that if I'm a health information technology system and I want to be able to integrate with cures, these are the requirements that I have to meet. And so all health information technology systems would have to meet these requirements. So from the medical board standpoint, when SB 42 and the requirement to check becomes actually in place, we would use this probably use some of the mechanisms in this in order to check. So basically, it requires when the physician checks, there's a means for us to be able to look and follow that trail that the physician checked. That allows for this. Now, it doesn't say the authorized user has to be the patient, the physician that's treating the patient, but that's required in 482. So it doesn't restate that, but I'm looking at it as two different issues.
Dr. Levine has a question. Go ahead.
Yeah, I mean, I think as I read the bill language, and it's pretty clear that this is enabling legislation rather than mandating legislation. In anything that makes it easier to do the right thing is a boon to both patients and physicians. So every click mitigated makes it easier for and more automated for physicians to actually check the system. Realistically speaking, my guess is the DOJ, I mean, this is going to take multiple years to actually integrate system after certified EHR system, and they're going to begin with those that represent the largest percentage. There's nothing in the language that, as I read it, that would require limiting this to 3 or 4 or 5 systems. But I think it's from a practical perspective, from an implementation perspective, they're likely to begin with Cerner, Epic, and NextGen, which I think are the 3 biggest systems. But they have to be certified EHRs. They have to have met the requirements for this. So that there's no risk of corruption of the Cures database, basically.
Yeah, Dr. Cross.
I think that the integration will be a boon to all practitioners, but I respect CMA's concern that we have a healthcare milieu of a variety of different types of practitioners, and every healthcare practitioner in his or her own practice has already spent many tens of thousands of dollars becoming compliant with a Medicare-approved EHR system. So if we were to create this great advantage and have an interface that really only plays with Epic, then many other health systems and physicians would feel obliged to maintain their own efficiency by spending another $10 or $20 or $30,000 to get that one system. So it would be nice if any health information technology system that is already compliant with federal guidelines and meets meaningful use could also be integrated with this technology that the DOJ will provide without great expense to individual practitioners or health plans. So I'm sympathetic with the concern.
If I could add, under Part E, it says the department may in its discretion determine whether to establish a direct system integration between one or more health information technology systems and the Cures database, or whether to develop a gateway system to which multiple health information technology systems can establish an integration for purposes of accessing the Cures database. While that's pretty open, if they, for example, chose to create a system that eliminated one or more vendors, that would be anti-competitive and would cost a lot of money for the practitioner. I think that's perhaps what CMA is referring to, but the overall concept is awesome and necessary. I agree.
Mr. Madden, you were the sponsor, so what do you got?
And thank you. I appreciate the opportunity to respond. I believe in that subdivision, the primary reason it says may is not to create the mandate. So we talk about not putting a mandate on the Department of Justice. So if we require them to do it, then that causes all other kinds of problems in terms of forcing them to do it. So that's why the discretion is still left there. But I would point back to the definition that Ms. Simoes read of a health information technology system. It's specifically written in a way to allow it to be applied to all health information technology systems. It doesn't say Cerner, it doesn't say Epic. For us in the emergency department, there's great value to us, but we understand there's value to physicians in office-based settings as well, and by no means do we want to stop that. So I just want to emphasize that that's not our intent. We have met with CMA on multiple occasions, and we'll continue to meet with them. We are open to tweaking the language to ensure that that does not occur. But at this point, we haven't received anything from CMA as to tweaks to the language to do that. In our discussions with the Department of Justice, we are seeking technical advice from them, and they have not indicated that the way the language is drafted causes any problems limiting which health information technology systems could seek the integration. So I'd like to point that out. This similar definition was also used in Oregon as they needed a statutory change as well. So there is some precedent for this language being used. But once again, we will continue to work with CMA to ensure that we meet the concerns as they're relevant.
Jennifer, so I would, there is a motion made and seconded. I would, if the okay with the authors, I would add that it's a broad integration with the broad systems used by physicians. Without that, what good is it? If you don't, it has no value. It might work for some people, but not for most people. So what you want is it should work for all California physicians as long as they're using one of the federally approved IT systems. So with that, I think I have no problem in calling for a vote, and I think we won. Dr. Levine.
Yes, I wonder if Dr. Lewis would accept a friendly amendment, given pending the tweaking of the language that we support in concept. Is that a problem?
So how would then that?
Well, we've done this before. We voted to support the legislative intent and support the intent of the bill, and wait for, it's really early in the session to wait for further update from Ms. Simoes on the process of language tweaking, if you will.
I'll change the motion to do that. I will second that.
Okay. Any other comments on the amended motion? Any comments on the phone?
No comments on the phone.
Thank you, Ms. Toof. Roll call, please.
Dr. Bolot?
Aye.
Dr. Bishop?
Aye.
Judge Feinstein?
Aye.
Dr. Hawkins?
Yes.
Dr. Kraus?
Aye.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton-Wills?
Yes.
Mr. Wormuth?
Aye.
Dr. Yip?
Aye.
Dr. Ganadev?
Aye.
Thank you.
Motion passes. Thank you.
Thank you. So I just have one more item. That's the status of pending regulations. If anyone has questions, the only thing I would like to point out is the disciplinary guidelines were actually approved and effective January 5th, 2017. And other than that, that concludes my presentation unless anyone has questions on the regulatory matrix.
Thank you, Ms. Simoes. Any questions on the regulatory matrix? Any public comment? Any comments on the phone? Thank you, Jennifer. Next agenda item is 19, update from the Department of Consumer Affairs. Ms. Lally.
Good morning, President, members, and Happy New Year to everyone. Always a pleasure to be with you. I am Christine Lally. I'm the Deputy Director for Board and Bureau Relations at the Department of Consumer Affairs. On January 10th, Governor Brown released his proposed 2017-2018 state budget, and earlier this week, as probably many of you know, the governor also delivered his State of the State address. Information on both of these important events were distributed to all executive officers and board members. On January 13th, Governor Brown appointed Jolie Onodera as the Deputy Secretary of Legislation at the Business Consumer Services and Housing Agency. Prior to her appointment, Ms. Onodera served as the principal consultant for the Senate Committee on Appropriations. We're very happy to have her on board. As we begin a new legislative session, several Department of Consumer Affairs boards are scheduled for sunset review hearings on February 27th and also on March 6th. As you are aware, especially the President, the Medical Board and the Department of Consumer Affairs are scheduled for their hearings on February 27th at the State Capitol. So we will see you that day.
On the hot seat. That's nice.
As we kick off a new year, the department would like to remind all board members of the importance of your required trainings. An email was sent to all of you and all programs at the end of December, which included details on training frequency and registration. Board members are required to complete orientation training, as most of you, I think, have already completed, within 1 year of their appointment and also upon reappointment to the board. This one-day training will be held 4 times in Sacramento this year, starting on March 21st, June 20, September 27th, and November 15th. Board members are also required to complete online ethics, sexual harassment prevention, and defensive driver trainings. Please note that 2017 is a mandatory sexual harassment prevention training year for the Department of Consumer Affairs. So this means that all employees, as well as board members, are required to complete the online training in 2017, even if you completed it last year. If you ever have any questions regarding the required trainings, you can always reach out to me or obviously your executive director. And just to really touch quickly on the trainings, I look forward to working with you, Kim, as we've had a brief discussion on the diversity training. I think it's a great opportunity for the department, not just the medical board, but all of our boards and bureaus. So I really look forward to working with you and Solid on that. Thank you. On January 4th, a memo was emailed to all board members regarding the annual Form 700 filing. The Form 700 filing deadline this year for your calendars is April 3rd. You are required to file annually, even if you do not have any reportable interests. As you may remember, last year was the first year that we went with NetFile, which is an electronic filing system. If you have any questions again about NetFile or your Form 700, please reach out to us and we can obviously assist you. And we have a conflict of interest officer, Jill Johnson, dedicated to the Form 700 filing that is always available. And obviously the deadline is April 3rd, but we encourage you to do it as soon as possible. Next, I would like to update you on the Breeze system. There are 2 upcoming Breeze software releases on February 15th and March 29th. These software releases will implement requested system changes by the medical board as well as other DCA programs. In 2016, 75 medical board system change requests were executed. An additional 10 requests were implemented during the first software release of the new year just a few weeks ago. Currently, there are 64 outstanding requests for system changes for the medical board that are waiting to be scheduled for future software releases. And finally, this morning, I wanted to let you know that the department's annual report is now available on our website at dca.ca.gov. In it, each program, including the medical board, notes its major accomplishments for the previous fiscal year, as well as new laws and regulations. It's really a helpful resource with licensing and enforcement summaries, staff information, and more. So I really encourage you to check it out and see where the medical board compares to some of the other programs. And with that, that concludes my update to the board today. And if you have any questions or anything you'd like me to take back to Director Kidani, I'm happy to do so.
Oh, thank you, Ms. Lally. Actually, if you could take back that we took enough of those courses that we can teach them, I think I would appreciate that too. Any questions from the board? Dr. Bishop.
Always Dr. Bishop.
The ubiquitous, yes. I received an email saying that I'd be notified later of the Form 700. So will I be receiving some sort of an email again, or do I need to talk with my EO and make sure I do this properly?
Sure. And you received the one on January 4th?
Something had said, but you'll just receive something. This is just a notification you need to do it, but we'll give you the real one later.
Yes.
Everybody else received that too? Other people are confirming. Okay.
We can check it out, but if you do remember your NetFile login from last year, you can go in there at any time.
Okay,
the system's available 24/7.
Thank you very much.
But I will definitely follow up with you and make sure you're good to go.
And if you don't remember your NetFile login?
We can get that to you. Absolutely. Yeah.
Take a poll on how many people.
Okay. Note to self. Send out the NetFile login to all members. Absolutely.
All right, Dr. Lewis, you are out of order. Almost nobody remembers NetFile login. So, any other questions? If not, any public comment? Any comments on the phone? Thank you, Ms. Lally.
Thank you. And again, Happy New Year.
Happy New Year.
Thank you.
Next one is agenda item 20, vertical enforcement program update from the Health Quality Investigative Unit, Mr. Chris and Ms. Nichols.
Good morning. My name is David Chris, and I'm the Chief of the Department of Consumer Affairs, Division of Investigation. And this is Deputy Chief Kathleen Nichols. We will be providing an update on the Division's Health Quality Investigation Unit. Last meeting, we advised of our plan to mitigate the sworn investigator vacancies by adding 15 limited-term, non-sworn special investigator positions. I'm pleased to report that all 15 positions have been filled, and the investigators are working on medical board cases. 8 positions were added in the San Bernardino office, 3 in Valencia office, and 4 in Sacramento. This project has been so successful that 5 of the special investigators who started in San Bernardino on October 3rd, 2016, are now in background for sworn positions with HQIU. While they are in background, which is a 10 to 12-month process, they can continue working cases and assisting with the workload. We have received very positive feedback from the field and the Attorney General's office regarding this group of new investigators, and will continue utilizing this model until all of our vacancies are filled. Our current sworn investigator vacancy rate is 29 vacancies, which is 38%. We currently have 12 people in background for sworn positions. We've also mitigated this shortage by employing the 15 limited-term special investigator positions. As mentioned, the non-sworn pilot has been a huge success, and we plan to continue this model to recruit for our own vacancies. Additionally, we have advertised 3 limited-term, non-sworn special investigator positions in the Tustin office and 1 in the San Diego office to backfill some of the San Bernardino special investigator positions that are now in background for sworn spots. San Bernardino was an office with no sworn investigators, and we now have 2 sworn candidates working and 4 more sworn candidates in background. With the plans we have implemented, I am confident that we have turned the corner regarding the vacancies and will work diligently to fill the rest of the vacant positions. And then Kathleen has some information about recruiting.
Yes. To assist with recruiting for our vacancies, we've developed the new card brochure, which you've all received one now, that utilizes QR Reader so that potential applicants can scan the brochure with their smartphone, and it will take them directly to the current job postings for HQIU. It's often difficult to navigate the hiring process with the state and guide applicants to your agency's specific openings. This is a creative approach to reach a large number of people with specific links that go directly to our positions. We are conducting outreach efforts with local law enforcement agencies, colleges, police academies, and professional groups. And in addition to that, we are also developing a recruitment video for our DOI website.
And with that, an important aspect of all the recent hiring is to retain this staff. And as you know, we've submitted an investigator pay retention proposal that is pending with CalHR. We have been advised the retention pay proposal is still being evaluated by CalHR, and we are waiting for a decision. We are also working with the medical board on new reporting functions with QBERT, which will allow us to accurately pull case aging statistics. We hope to go live with this reporting function in February of March of this year. Any questions? Yes.
Yeah. Dr. Lewis.
Thank you for that very brief and concise report. Appreciate that. Again, about every board meeting, we talk about R&R. I mean, I've heard this for a long time, and it's always with CalHR. And at one time at a board meeting here, we talked about getting some pressure, either legislatively or some other way, to impress upon CalHR the importance of these positions and your inability, because of competition and bargaining and stuff, to hire. Where are we with that?
We've elevated that through our director as high as we can go, and we've been told that they're still evaluating it at CalHR. So I don't know what else to add to that. It is that we've pushed to the highest levels, and that's the response that we're getting, and I am hoping for some type of positive response back.
You finished bargaining, so that it's out off the table now, so there's no other way. But I feel your pain, and I just bring it up again because it's always a topic here.
Yes.
Thank you. Yeah.
No, I greatly appreciate it, and we have pushed to the full extent, and we're still hopefully waiting.
So Mr. Chris, did I hear right? You have 38% vacancy?
And that was in the sworn investigator ranks. That's mitigated by our non-sworn investigators that we've hired, which is 15 full-time non-sworn positions to mitigate that, as well as 12 people in background.
Okay, so our frustration here is, like President Reagan said, we pay for it.
Correct.
It's our board. We take every hit from every side, from doctors on one side for taking too long, and from the consumers on the other side because consumer safety is jeopardized. So, and we are saying we're going to pay for it. So where does this bureaucracy, when does it end, where we, as the payors, where the money doesn't come from general fund, it comes from physician licensing fee, we're willing to pay. We want to make sure that we streamline this process, and we get stuck in the same thing every board meeting. It's a frustration we are feeling because we are the ones ultimately responsible, nobody else. It's our job.
Yes, and I am even more frustrated than you with the state processes that we have to follow, and what I think we've done is do something different that was done in the past, and we've created this non-sworn investigator unit to get people in and who don't have that experience that the sworn investigators have, and to get them started, and they're young and they're energetic and they're interested in these cases, and we get them working, and we get them working very quickly. And we're going to keep using this model it's been working. And so we're going to continue to use this model to fill our vacancies from now going forward. And so I think some new and creative ideas have been put into place, and those are going to be working. We've been talking with the AG's office and with Kim at the board. This seems to be a model that is showing results, and moving forward, it will take time to fill the vacancies, but it is something that's different and hasn't been done in the past, and it's new, and it is already working. We're showing some progress. So I know it may sound the same, however, there is hope, there is progress, and this model looks like it's going to be one that we can use going forward for success.
Thank you. Actually, one bright idea. Hopefully it will take off. Any other? Yeah. And Judge Feinstein.
Thank you. Let me make sure I understand correctly. I haven't quite been on the board a year yet, but this 38% vacancy rate in terms of the sworn investigators seems to have been the vacancy rate during my nearly 1 year on the board. Am I misinterpreting what you're saying here today, that it is your intent to accept that we're not going to have those sworn investigator positions filled and we're going with non-sworn personnel from here on out?
No, that is the vacancy rate at 38% is mitigated by the non-sworn investigators. That's a temporary pilot project to fill the gap until the sworn vacancies are completely filled. Many of these non-sworn investigators want to become sworn investigators, and so in order to do that, there's a long background process in an academy that they have to attend. While they do these mandatory things, the background and the training, they still work for us, and they still do cases, and they still are very beneficial to the agency, versus hiring somebody from the outside who can't even touch a medical board case until they pass the academy and go through the background process. So we're really killing two birds with one stone. The non-sworn group works for us now. They didn't have to attend an academy or go through the background process. They can do that while they work for us. So it's really it's a two-pronged approach.
It's a pipeline program.
Yes, and it's a pilot program, and what it does is those positions are limited term. So they will, when they expire, many of those people will be sworn investigators, and so it's accomplishing filling the ranks and getting the workload done at the same time.
And are other efforts underway to fill the 38% sworn investigator vacancy rates?
Yes, and those were some of the things that we mentioned with career fairs and talking with the police academies and recruitment in general. But the 15 non-sworn investigators will actually mitigate that 38% vacancy rate, as well as the 12 investigators that we have in background now that are from outside the agency. So all of those are candidates for those 29 vacancies.
All right. Thank you.
Mm-hmm.
So what it means, I guess, Judge Feinstein, is that we see a little light at the end of the tunnel.
Yes.
One day we will.
Yes.
Thank you. Mr. Varma.
Just by clarification, which is along what we were just talking about, when you say you see progress, you're talking about seeing progress in filling the vacancy.
Correct.
Not in lowering the number of days in process for the cases.
That is correct.
Okay. Given the progress you see, do you have any idea of when we might start to see?
Yeah, I'd like to report.
Progress
I'd
on
like
the
to
other
report
part?
progress in the numbers at the next meeting. Yes.
Okay. Thank you.
Dr. Levine.
If it's great that you're filling the bucket, but what's happening with the hole in the bucket in terms of departures and people, sworn investigators, leaving?
I think it's important to acknowledge that, as Dr. Feinstein mentioned, the vacancy rate appears to stay the same. It's not that we're not hiring people, it's that they're still leaving because of the pay inequity and because of the workload inequity. And so this problem with the pay needs to be addressed, because otherwise we'll hire all these people and then the hole's still in the bucket. So I think we've elevated it as high as we can. If the board can do anything to contact CalHR or express the fact that you are special funded and you are willing to pay for this retention proposal, that could go a long way.
And what number of sworn investigators have you lost in the last fiscal year? I mean, is it?
Since transition, we've lost 47 sworn investigators.
Wow. 2 years. A little over 2 years.
Bargaining unit? What's the denominator?
It's bargaining unit 7. Unit 7.
Oh, Law Enforcement Association.
Okay, any other questions?
Yeah, sorry, just 47 out of the number of positions you have?
Well, there's 77 investigators, and then there's supervisor positions too that make up 97.
Okay, but the 47 who have left are not supervisors, right?
Some are supervisors.
Okay.
So out of the 97, we've lost 47.
And we've
2 years.
2 years, a little over 2 years. And so we've hired back some of that 47, and the current number is 29.
Thank you.
Thank you. Any other questions from the board? Any public comment? Any comments on the phone?
No comments on the phone.
Thank you, and thank you, Mr. Chris and Ms. Nichols.
Dev?
Oh, I'm sorry.
I just have a specific question about the pay issue. Is it that they're not meeting a specific pay rate of sworn officers?
There's competition from the industry for other cities and counties and state government jobs pay more for this type of specialty.
And so is there an industry standard or a city standard that is the norm that we're not meeting?
You know, the Unit 7 investigators get paid the same rate, and there is more pay for similar jobs at the Department of Corrections and at the Department of Justice and the ABC, Alcoholic Beverage Control. All of those groups pay more, and so typically when staff leave, they'll leave to a higher paying job.
Is there a specific area where they're leaving to?
DOJ and corrections.
CPOA.
And the wages are considerably higher.
No, thank you. I think you told us this multiple times, and so we are trying to see how we can. It's, as I said, it's our money. It's our investigators. I know we transfer them to DCA by law this time, but you are our people. So, thank you.
Thank you.
Okay, the next agenda item is item 21, Vertical Enforcement Program update from the HQICS. So, Ms. Castro.
Good morning. It's always a privilege and an honor to appear before you. I wanted to definitely focus on the existing work at HQIU and the existing workforce and what we've been up to, notwithstanding these challenges that Mr. Chris and Ms. Nichols have described to you. In November 2016, we had 2 subject interview trainings in Northern and Southern California. The Northern California session was observed and attended by the Deputy Secretary and General Counsel of the Business Consumer Services and Housing Agency, Peter Williams. He himself firsthand saw the collegiality between our investigators and DAGs, and in an atmosphere where we're all trying to protect the public and also increase the quality of existing work members on your cases. At the same time, there has been an observable contraction of non-core disciplinary work by the Health Quality Investigation Unit, and I think that that is having a positive impact on your cases. They have shed 2 clients. 2 clients have gone over to the other side of the shop at Department of Consumer Affairs' Department of Investigation, therefore reducing some cases from their workload. They've also redirected their work on criminal cases. We are seeing in HQE at least less of the search warrants and criminal cases and more focus on the disciplinary work, which is your core mission. And at the same time, it has been welcomed by our shop that a lot of lawyer functions are being given to my DAGs who are eager to review and draft and edit subpoenas and rewrite them as necessary. We've also worked very closely with Ms. Webb and DCA counsel on trying to more clearly illustrate and enunciate the interrogatory authority that should be given to HQIU on your behalf. Interrogatories allow investigators to ask very specific questions of subjects, especially in cases where we are not able to get patients. As you might imagine, there are certain core areas of negligence in the medical community where there is very little patient cooperation or even difficulty in identifying patients. We continue to operate in a virtual shared workspace with our investigators, and there have been some efficiencies there, such that days and times have been shaved from overall aging. At the same time, we have a hurry up and wait approach. As work gets completed, we are putting all hands on deck. We've increased the level of lead prosecutors out in the field.
to get ahead of any statute of limitations issues. We would like to operate in an environment where physicians are cut loose from the cloud of suspicion in the investigatory phase, and also that we are able to prosecute physicians who do deserve to have disciplinary charges against them. But at the same time, we continue to work in a very collegial and stressful environment with our partners at HQIU on your cases. But from where I sit, I've seen Mr. Chris and Ms. Nichols try their best to address these issues, and I just wanted to take that time to focus on the work at hand that we do every day for you. And with that, that concludes my BE report.
Thank you, Ms. Castro. So this is the sunset year. So the new legislation coming up, I would love to have you, AG's office, and DCA to work with my staff here to see what legislative changes we can come up with to really streamline and expedite the process so that there are not these bad doctors hurting people too long, or the good doctors who are bad, whose name is tarnished for too long. So it just makes no sense to us here to have this process take too long. So it needs all three, not just the medical board. So Ms. Kirschmeyer knows, Jennifer knows, and I talked to Ms. Lally. So we need to really see some innovative changes. We can sell it to the BNP committees. I'm willing to do whatever you guys want me to do. But it's one of the biggest prerogatives is to see what changes we can make in the legislatively to see how we can expedite, other than the investigators' numbers and all that. I understand that, but we also can look at whether the timeline with the doctor needs to respond, the timeline, the breaks we give to the defense attorneys for multiple times canceling. There's so many things we can change. Thank you. Any
And
questions
we'd be
from the
happy
board?
to help.
Thank you. Judge Feinstein.
Hi there.
Hi.
As you know, Ms. Castro, VE is one of my larger concerns. It's not necessarily a concept I have yet in my legal life of 30-plus years to really see work. And I would like to believe that it works well in this context. Toward that end, it would be, I think, of great use to the committee, and I know I'm personally interested in knowing how many cases really are vertically handled. Just to echo a little bit about what Dr. Gonadev just said and has been expressed in the various panel discussions, we are seeing cases come before us from 2010, and that means, or could mean, that we have a very dangerous doctor who is out there in practice for 7 years treating people because it's taking 7 years for the case to get to us. And I'm not pointing a finger as to why that is, but that's an unacceptably long time. And in terms of whether we choose to remain with this vertical enforcement model, I think we need some more information. And if we could even have information about the cases that have been presented to us for the past year or 2 years, and how old they are, how many did investigator A start out on it with DAG 1, and are we still with investigator A and DAG 1 at the end? And I would think that we probably aren't over a 7-year period, especially considering what we just heard about the rate of investigators. And I just think that to have something that's only in name doesn't serve us well. And if we need to look at new models of investigation and prosecution, we should, and we should be open to doing that. And if there's any way to provide those numbers, and I don't want to increase your workload, or I don't, that's not my intent, but we need to know this to make an assessment. And it's sort of up in a cloud there for us. And, you know, I am happy to meet with you if you're willing, or with anybody that is interested in this, because we've got to figure out a better way.
And we appreciate all those comments, and I did hear you loud and clear at our last meeting, and I did go back into our pro-law system to see, well, let me see if I can get Judge Feinstein what it is that she needs. And traditionally, HQE has really focused on the legal aspects of the work. We do document the first investigator that is assigned, but we don't take great pains to keep the investigator assignment up to date. We are operate in a team-based environment where everyone's on the team. So if that investigator is no longer there, we always know who's assigned, even though one of our case coordinators didn't go back and bill the board 15 minutes to put in the new investigator name in pro-law. So I really did hit a challenge because we have not maintained that data. I can tell you how many DAGs have touched a case, but again, it's a team-based environment where we have supervising deputy attorney generals, lead prosecutors, and the primary deputy attorney general operating on a case. So if the definition that we're playing with is, did the same person stay assigned the entire time, that is the goal. And obviously, in light of the staffing challenges with investigators, it's not a reality. But if we focus on the definition of vertical enforcement to mean that each side of the investigative process, the investigator who has probable cause to investigate and collect evidence, and if you look at it from the attorney's perspective, we're trying to cut loose folks that are innocent and include in folks that need a closer review such that legally and admissible evidence can be obtained, proper experts can be retained to provide those opinions, and the right people are prosecuted by the signature of Ms. Kirchmeier on an accusation, then we're accomplishing that task. The only other way to do this is the deputy and district office, and that is what we had about 11 years ago. I think that the model that we are operating on, as I described last time, is a hybrid model. And Ms. Nichols and I meet regularly, and we've made the best of what it is that we have. Anything less than we have right now, in concept, not in reality, but in concept, just our protocol and how we operate, and two team-based cultures meeting in the middle and bringing the best of both worlds to bear on a case, it's running as good as it can in light of the reality of resources and time. But I can most definitely take the time to talk to Ms. Nichols and see if this is something we can produce. We've been very focused on the cases.
Or if I might ask, may I ask a
please.
follow-up? What if we just look at the Attorney General's involvement? And I mean, I know from having been a prosecutor myself that if you shift a case from prosecutor A to prosecutor B has to repeat or at least review all the work that prosecutor A has done. And then if it goes to C has to repeat it. And I think it would really help us, even if it's just from your office's perspective, and we don't look at the investigators, to know how many, not supervisors, not leads, not, all the way up the chain of command, but just how many lawyers the case has been assigned to. We may find that is a cause of our delay. And I'm not saying the main cause, but a contributing cause, because we've got to start figuring out what parts of the system we can tweak to move these cases more quickly.
I think your request is achievable for cases we've presented to you that are true vertical enforcement cases. I will say that We don't have staffing challenges other than people accepting judgeships or moving on because they deserve it and they're retiring. So the staffing challenges that HQ has do not exist in my office, even though we're underpaid and paid as much as other folks that we believe we work harder than.
Well, actually, I'm sorry, but when I was looking at some of the budget documents, underpaid may be irrelevant because our expert reviewers seem to be paid the same hourly rate that your office bills the board for their legal services.
Right.
So I can let that one just hang.
Well, we don't work 40 hours a week, so when you extend it to 60 hours and you're still reducing it, it works down to less than that hourly rate. But I don't want to take issue with that at all. I think it's something that it can be achieved, and we can probably show you. But notwithstanding whatever we come up with, I think it's a better model than getting a case cold and not knowing anything about it and having to see the evidence for the first time presented to us after years of it sitting in an investigator who's working in a silo and thinking that this is what they should present to the Attorney General's office. Obviously, it's a model that we do use with other clients to this day. The reason why vertical enforcement is not used with other clients is because their cases did not merit that, and from time to time, our clients who hand and cherry pick cases that do deserve a fresh set of eyes very early on, those are identified. So that is what we do for other clients, and that is certainly what I believe we did previously, which was called the Deputy and District Office model.
Well, maybe you can help put my fears to rest then with this information.
Well, we'll try to present you with the most objective information that we can and let you draw the conclusion. And we can continue to discuss the 20% of our work that we do for you. I'd like to stress that. VE is 20% of my overall budget, at least on billables. Each DAG handles up to 40 investigations at a time. We see about a 1,500 turnover rate, 1,500 investigations either come in or are completed every year, even though New York, it's a continuing cycle. Right. New things come in, things get worked on, and things get shed. But it works out to about 1,500, and I'm including the Complaint Investigation Office in that number. And we bill about 2.5 hours per case. And most of that time is devoted to doing hard legal tasks. The lead prosecutors, there's 12 of them, one in each district office. They do a big share of the work where it comes to high urgency types of topics. So they will handle that case to the extent we're presenting you a petition for mental and physical evaluations where we feel somebody needs to be compelled. They handle difficult subpoena enforcement reviews. They fill in for my trial deputies because they're all trial deputies. And from time to time, the subject interview is scheduled on a day where my staff is in trial on one of your cases or in civil court defending one of you. And there is no way that that DAG can be in two places at once, although we'd like to clone some of them and make that a reality. But the lead prosecutor fills in on those specific tasks. So this is 20% of our workload. It's very important. Most of the cases do close, and about 250 to 300 cases become cases out of that whole corpus. But certainly we appreciate the fresh eyes. I do appreciate all the questions, and we did take it seriously, and I really couldn't accomplish that, the task of identifying what cases had new investigators. It's just with resources, we just didn't, we don't track what the client does. If the client's already tracking the stats, unless we're asked very early on, we don't create that system. But we can certainly keep an eye on it, on that small group of cases that you have seen as a board for a specific amount of time, and I can assign an AGPA to try and track that down and tell you, of these, this is how many started with this DAG and ended with that DAG.
We appreciate it.
And then we can send that list over to Ms. Nichols, and I don't know what her analysis would show. But
I'll even take it just from the Attorney General to start.
what's my deadline?
Actually,
She's a judge. What do you think of?
So Ms. Castro, I think,
Yes.
Catherine. So if Catherine, if you're willing to really look into and bring it back to this board along with Ms. Castro to the enforcement committee, I think I'm great. I would love it. So it's up to you. So this board will
All
be
right.
happy to have
Why
you.
don't we talk and figure that out?
It'd be our pleasure. When's the next enforcement committee meeting?
It'll be when we need one.
So next February or something?
No, probably either July, possibly April, depending on if we have enough agenda items.
Make it July.
Thank you, Ms. Castro, and Kim.
I just wanted to provide some clarification. Judge Feinstein stated that she's seeing cases from 2010, and those are the incident dates that you're seeing. It's from the incident because our current processing time right now is 967 days, which is about 2.5 years, which is still too long, obviously, but I just wanted to provide clarification that we're looking at incidents, and then it takes a while for the medical board in some cases to get those complaints, be it maybe their mandatory report. And then I did want to draw everyone's attention to 11B12. When we start talking about statistics, I would encourage anyone that wants statistics outside of what we already pull. So we pull statistics from 11B12 to 11B20, and I would like, before we start getting statistics, to really go through those to identify what beyond what we're already providing you would need, because there's a lot of statistics in the data that's provided in that section, and I'd want to have direction to look at those first before we start identifying other factors, okay?
And I did.
Okay.
Thank you, Kim. I'm just willing to do whatever it takes to really cut down the timeline. That's all I can tell you. Any public comment? Any comments on the phone?
No comments on the phone.
Thank you. That then we'll continue to hear from Ms. Castro for the next agenda item, which is update from the AG's office. Ms. Castro.
Briefly, we'd like to express our gratitude to Diane Dobbs. She has been a fabulous person to work with over the years. Peggy Tarwater, my lead prosecutor, and I are very upset to see you go, along with the other staff that had the pleasure to have to work with you on our STIPs and on any other number of things. We have full faith that Carrie Webb will be able to carry on your excellence with your departure for greener pastures. So thank you so much for teaching us everything there was to know about licensing. And I don't know, can you hear from us? Probably not. We can't call you. So you chose a good job, because then we probably can't bug you anymore. I'm pleased to tell you that HQE has a very good relationship with the Office of Administrative Hearings and the man that is Judge Alvord. Judge Alvord is a presiding judge in San Diego and is also a leader in the Office of Administrative Hearings. We meet with him as much as possible, or I do, to discuss efficiencies in the administrative hearing process. This includes trying to figure out how to quickly manage failures to appear at hearings by way of default, managing our staff's expectations with respect to managing requests to set in front of them, and trying to get trial settings quickly set for you. I'd like to point out that Judge Alvord did take a very important submission and recommendation by me, and is attempting to the best of his and his staff's ability to set vertical enforcement cases ahead of all others. I did explain the statutory function of vertical enforcement, how it requires that the same DAG be assigned to the case, and as such, my DAGs are not fungible. One of the things that OAH was forcing us to do was they were double setting our cases with some frequency, and causing us to have to kick off a DAG that had been assigned to that case as a vertical enforcement matter, and they were forcibly removed, and somebody else had to come in at the very last minute to cover for that. After he understood that it is one of the goals that the same deputy assigned to the investigative process be assigned throughout the life of the case to its ultimate determination, he has started to to at least acknowledge that when we say my DAGs are not fungible on these types of cases, he has stopped, or at least trying to double set our staff. He'll still set them back to back, but my DAGs are superstars, they can handle it. We continue to handle cease practice orders as they come, and we appreciate the value of having Ms. Delp at the head of that unit. And with that, very quickly, we have a case. It's called Alyssa Cross. It's set for the Court of Appeal in Los Angeles on February 8th. It deals with very important subpoena enforcement defense. And with that, I'll just add that we did hire a DAG in San Francisco. Her name is Alice Wong, and she was in private practice in Sacramento, and previously to that, she was in the Sacramento District Attorney's Office. And with that, I conclude my remarks on my AG update.
Thank you, Ms. Castro. Any questions from the board? Any public comment? Comments on the phone?
No comments on the phone.
Thank you, Ms. Castro.
Thank you.
Then we'll move on to the agenda item 23, discussion and possible action on amending Title 16 of the California Code of Regulations, Section 1321, pertaining to approved postgraduate training. Ms. Alameda.
Hi, I'm April Alameda, Licensing Program Manager. Please turn to Board Agenda Item 23.
Welcome to your first meeting as the...
I know, I really miss Kurt. We talk weekly, though.
I still called him for something, so it's a
You can't
relationship
stop.
which goes on 5 years, so go ahead.
The board currently approves postgraduate training accredited by the Accreditation Council for Graduate Medical Education and the Royal College of Physician and Surgeon of Canada, completed in the United States and Canada. Both the ACGME and the RCPSC now have international divisions that accredit postgraduate training in other countries. At the January 31st, 2013 Licensing Committee Board meeting, the committee advised staff to continue to monitor changes in postgraduate training and bring new information back to the board when appropriate. The postgraduate training programs accredited by the American Osteopathic Association are in the process of being accredited by the ACGME. Board staff has been receiving inquiries for clarification regarding the transition of the AOA accredited programs to ACGME accreditation and how this will affect an applicant's eligibility. In addition, staff has received questions regarding the international programs and whether the board recognizes the international postgraduate training programs. The ACGME and the RCPS International Accredited Postgraduate Training Programs are similar to the programs in the United States and Canada, but not identical. Therefore, no, we are not asking for approval at this time. In addition, the board has become aware family medicine postgraduate training programs in Canada are now accredited by the College of Family Physicians of Canada. Therefore, we are requesting that to amend California Code of Regulations Section 1321 to clarify the regulations to address the recent changes to postgraduate training. The opposed amendments are in your packet. They're on the second page. And I'm requesting a motion to authorize board staff to move forward with amending the regulation.
So moved.
Second.
Okay, any comments from the board members? Dr. Yip.
I'm sorry.
This is different from the 1 year versus coming up 3 year requirement, right? Okay.
That's correct.
Thank you.
Okay, any comments from the audience? Comments on the phone?
No comments on the phone.
Okay, Ms. Stoof, roll call, please.
Dr. Bolat?
Aye.
Dr. Bishop? Aye. Judge Feinstein? Aye. Dr. Hawkins? Yes. Dr. Kraus?
Yes.
Ms. Lawson?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Pines?
Aye.
Ms. Sutton-Wills?
Yes.
Mr. Wormuth?
Aye.
Dr. Yip?
Aye.
Dr. Gonadev?
Aye.
Thank you.
Thank you. Motion passes. Thank you, Ms. Alameda. We'll move on to agenda item 24, update on the interested parties meeting that was held on January 11th regarding disciplinary guidelines for patient notification and regulations for the Physician Health and Wellness Program. Ms. Kirschmeyer and Ms. Webb.
On January 11th, the board staff held an interested parties meeting to discuss potential changes to the board's disciplinary guidelines to include a condition for patient notification and also to go through the potential regulations needed to implement the physician health and wellness program. And I think Dr. Kraus had asked for a update on the progress, so this is your update that you asked for yesterday. You beat us to the punch. On page BRD 24-1 is the handout that was provided regarding options for patient notification. The recommendation was that the board could use one of these options in the disciplinary guidelines. By putting the requirement in the disciplinary guidelines as optional, as an optional condition, then the board would be able to choose on a case-by-case basis when to require the notification. The difference between the two options is really that one is a posting of a sign and is modeled after the Board of Optometry guidelines, and the other is a written and verbal notification to the patient. There were comments received from those that were in support of the options and those that were not. Those that were that supported the option also thought both options should be available instead of choosing one over the other. When we were first looking at it, we thought maybe we could use one and not the other, and it was recommended that you put both out there because then that even gave the board more latitude, as well as individuals going through the process at settlement to use one or the other, which would work best for their practice. Then the comments, the other thing that they stated, of course, those that were in support, they also did think, though, that they would rather have it not be optional and that would be required for all individuals. But the board did reject that petition earlier on. Those that were not in support of the requirement stated that any type of notification is in essence a suspension for the physician, that the requirement will have an impact on staff because patients will ask them about the information, and that's the doctor's staff, that some website advertising isn't within the physician control, and that this will require more cases to go to hearing. At this point, staff believes that there are a few edits that can be made to the document to respond to some of the comments and concerns, and we can make those changes and then later bring the matter back to the board for discussion at the next meeting. And then Ms. Webb's going to talk about the physician health and wellness regulation portion of the meeting.
So for presenting on the physician health and wellness program, I put together a PowerPoint that broke down the law allowing the board to establish this program and put thoughts on what the regulations would have to entail. As part of this, I broke down the uniform standards for substance abusing licensees, which are required to be a part of any physician health and wellness program, and really explained to the interested parties in attendance how these would have to be incorporated into the program. It was very educational, I think, for everyone involved with how rigorous this program will have to be in ensuring that the board is informed of violations, whether they be major or minor. This is not a diversion program, and public safety is going to be paramount in the implementation of this program. So the step now is we are taking the comments under consideration, and I will be putting together draft regulations for probably another interested parties meeting before it comes to the board.
Thank you, Ms. Kirschmeyer and Ms. Webb. So any questions to our staff from the board? Dr. Bishop.
I may have missed part of this, but I'm reading this and it says under option 1 that they'll post a notice on any website advertising his or her services, but that does not include all the different services that are out there that just grab physicians' names, does it? That'd be impossible.
Actually, that is a comment that came up, and
Okay.
I must have missed that in my reading. Yes, that was one that came up as like, well, there's Yelp and there's health grades and there's this, and so we decided, we need to go back, and that's part of the language that we definitely need to tweak, because if it's outside of the physician's control, there's no way they would be able to identify even possibly that it was even out there. So, yeah, that's one thing that was the exact section that we really need to look at.
Any other comments?
Yes.
Dr. Krause.
Regarding the notification issue, do we know if other states have had similar actions, and what they found was the result of using that option in discipline?
I believe when we first started looking at this, there were no other states that have that patient notification.
Also, with regard to the optometry board, that first option with the posting of the sign and on any website that advertises the physician's services, that is an optional condition that they have not used.
Yes, Dr. Krause.
So we do have some experience with the issue, thankfully being brought forward to us by the Consumers Union Safe Patient Project. And there was a petition that was not supported. There's been legislation that's been not supported. And I think one of our overriding concerns is if we establish something in our disciplinary processes that makes signing a stipulation so egregious that we could be faced with a circumstance, as stated earlier, where many, many more cases are going to hearing, and the medical board becomes overwhelmed, being unable to process so many hearings. The other concern is that once this is an option of discipline, I can imagine that there may be circumstances where we feel it's an essential part of the discipline. But I think we then open ourselves up to an ongoing prospective analysis of how often the medical board is using that methodology of discipline, and then subsequent criticism for not using it often enough. So I see positive and negative in establishing this as a methodology of discipline.
Yeah, we would agree with you on that, just in going through it. At the same time, on the cases going to hearing, I think that would be something, because it would be in the negotiation process to where we go back and forth discussing it. I don't know if that would ultimately, if it was something that we'd ultimately hold to, then it might end up going to hearing. But the other thing is on those that go to hearing, the board has the opportunity to look at them and then decide if they want to put it in by either non-adopting the decision, or if it's in there, you could, and you don't think it was relevant as well. So that's why these two options really are going to be left up to the board's discretion to put them in if we did it this way.
Thank you.
So both of them are not fully cooked. So that's why they're not here for you to decide. I can tell you that. Any public comment? Marian Hollingworth? Julie D'Angelo Felmuth.
Thank you. Dr. Krause, I just wanted to add to the answer to your question. Currently, your disciplinary guidelines contain optional probation disclosure requirements, but only under two circumstances. One, where there is a required third-party chaperone, and two, where there is some sort of restriction on the practice or prohibited practice. And they're both optional. You don't have an optional condition of probation to require probation disclosure in other circumstances. And to the extent that this would simply give the medical board another tool in egregious cases, that's one of the reasons why we supported the options. And they're all optional, but it just gives you another tool outside those two enumerated circumstances.
Also, with regard to those two, what's unique is that while the physician has to disclose that they have to have a chaperone or that they have a practice limitation, say they can't give Botox injections, for example, they don't have to say that it's because they're on probation. They just have to say, this is required, please sign this log. This would say, I'm on probation, this is why, for information, contact the board, or here it is. So they are different.
Thank you, Ms. Webb. Marian Hollingsworth.
Hello, I'm here on behalf of the Consumers Union Safe Patient Project. We wish to address the board's proposal to amend its guidelines to make patient notification regarding probation an option, and the board's plans to promulgate regulations regarding a physician's health program. First, I would like to address a proposal regarding notification when a physician is on probation. The board proposes that notifications be an optional condition of probation. We strongly urge you to make such a notification a standard condition of probation in the cases of doctors who are on probation for serious offenses. In these cases, patient notification should always be required. Patients have a right to know that their physician is being disciplined and is on probation. The board suggests two possible forms of this notification. One option calls for a sign in the physician's office. We support such a sign, which would make information about contacting the medical board for further information. We also support requiring that the physician include this information on any web-based advertising. The other option the board puts forward calls for the physician on probation to notify each patient in writing and requires that the patient sign an acknowledgement of receipt of the notification. The patient's signature and the log that a physician would be required to maintain would provide assurances that patients actually received the information. We recommend that the board include both of these options in its guidelines. We do not agree with the CMA that this is an unfair condition on a physician. Under the proposal, the board will be using its discretion about when to implement such options. Many doctors who are on probation have been brought before the board multiple times. Patients put their lives into the hands of these physicians and have a right to know. Also, we recommend that a report be made to the board in a public meeting at least once a year regarding how these options are used. And regarding the board's proposal to promulgate regulations regarding a physician health program, there are three recommendations we would like to make. One, the medical board would create a committee whose responsibility would be to have oversight over the physician health program. Two, regulation should clearly require that the physician health program follow the uniform standards strictly as the staff had proposed. And three, regulation should specify that under no circumstances should the MBC secretly refer a physician into this program. This board would make no referrals to the physician health programs other than those that are accompanied by an official board action. The board should not refer doctors to this program instead of taking a public action. And the MBC should only refer physicians into this program under the circumstances that include making the referral public information on the Physicians Breeze webpage. Thank you.
Thank you, Ms. Hollingsworth. Any other public comment? Any comments on the phone?
No comments on the phone.
Thank you.
Dr. Gnanet?
Yes, Dr. Cross.
I'd like to remind the public that I'm very proud that when the Consumers Union did a national survey of every state medical board in terms of availability of information about physicians who have had actions taken against them, that California was found to be the best state in terms of ease of access of this information.
Thank you for reminding us that, and that was their research findings. So let's go to item number 25, update on public outreach, education, and wellness committee. Dr. Hawkins.
The Public Outreach, Education, and Wellness Committee met yesterday afternoon. The first agenda item was presentation of physician burnout from Dr. Searle, who's a clinical professor in the Department of Family Medicine and Public Health and Psychiatry at the University of California, San Diego. Dr. Searles gave an informative presentation that covered physician burnout symptoms, statistics regarding physician burnout, the effect of burnout on patient care, and ways to prevent burnout. The next item was a discussion on the physician burnout survey, which was presented by Ms. Kirschmeyer. The FSMB would like to work with the medical board on this survey, which is being used in New York, and the board can include the relevant portions of the survey in its license renewal survey. The committee agreed it was a good idea to collect this type of information, and Dr. Levine will be working with staff to develop this survey. Thirdly, the committee received an update on the Check Up on Your Doctor license outreach campaign activities from Ms. Simones. The The committee viewed the tutorial posted on the board's website, which walks patients through the process of checking up on their doctor's license, directed staff to make some changes to the tutorial, and directed staff to work on a PSA regarding what the board does in general, and that would encourage patients to use the board's website. The board has continued to implement the outreach campaign and will be including new developed flyers with all state warrants for active state civil service employees and UC employees in the payroll issued March 12, 2017 to reach 265,000 individual. The board is continuing to work with the counties, other state agencies, and other interested parties to encourage patients to check up on their doctor's license. Board staff also provided an update on general outreach activities. Finally, potential future committee meeting subjects included AMA staff providing a presentation on interventions on managing stress, having staff provide an update on physician health and wellness program. We heard a little bit about that just now from Ms. Kirschmeyer, Mr. Webb, and the public. And thirdly, a presentation with an update on marijuana as it relates to health implications, the new law in California, et cetera. That's the end of my report.
Thank you, Dr. Hawkins. Any questions from the members? Any public comment? Any comments on the phone?
No questions on the phone.
Thank you. I can see the tiredness. Next is, thank you, Dr. Dr. Hawkins. So next one is, what is it? Item 27. Update on Physician Assistant Board, Dr. Bishop. I hope you are.
The Physician Assistant Board conducted its quarterly meeting in Sacramento this past Monday, January 23rd. Board staff informed members that the CME audit program is working and currently 45 licensees are randomly selected following the renewal of their license. Board members were randomly selected board members were provided with sample initial CME audit letters and CME audit non-compliance letters for their review and comments. Following a lengthy discussion, board staff was instructed to research how other states conduct CME audits and to provide at the next meeting language for a regulation pertaining to failure to respond to the audit letter. And I also chimed in that perhaps I should discuss this with Ms. Kirchmeier, who has great experience with this. Board President Robert Sachs provided the board members with an overview of the National Commission on Certification of Physician Assistants, NCCPA. In order to obtain an initial California PA license, the applicant has to pass the National Certification Test. However, to renew the license, recertification is not required. Mr. Sachs indicated that currently 22 states require recertification as a condition to renew their PA license and be allowed to work in that state. Mr. Sachs stated that board staff contacted other allied health boards within DCA and not one of the boards require recertification for renewal of licensure. The members were informed that the PA board has been selected for internal audit by the Department of Consumer Affairs. A presentation was provided for the members regarding the process and timeline for completion, thus allaying much of the angst associated with that. Gloria Castro, Senior Assistant Attorney General, provided the members with an informative overview of vertical enforcement. The California Academy of PAs, CAP, CAPA, provided an update on legislative and regulatory changes relevant to PA practice in Michigan, Iowa, and the Veterans Administration. Michigan legislation amends Public Act 379 to modernize the Michigan PA Practice Act, which includes removal of reference to supervision and deletion to participating physician and practice agreement. Iowa legislation SF 505 required Iowa PA Board and Iowa Board of Medicine to jointly adopt rules to establish specific minimum requirements or definition of supervision for appropriate supervision of a PA by a physician. On May 25, 2016, the VA proposed to amend medical regulations in Part 17 of Title 38, Code of Federal Regulations, to permit full practice authority of 4 roles of VA advanced practice registered nurses when they were acting within the scope of their VA employment. Also, there was discussion with respect to the fact there currently is no expert PA involved in the initial evaluation of complaints against PAs, and the board is investigating, along with Ms. Kirchmeier, if this would be something reasonable to include in the enforcement process. Lastly, the DHCA Budget Office provided a 2016-17 expenditure report which indicates a deficit of 23.3% due to rising AG and investigative costs. A budget augmentation will be requested for these two line items. The members also discussed a possible BCP for fiscal year 18-19. This concludes my report.
Thank you, Dr. Bishop. Interesting what went on there. Any comments from the board? Okay, any public comment? Any comments on the phone?
No comments on the phone.
Thank you. So we'll move on to the next agenda item, number 28, items for the April 2017 meeting in Orange County. Any board members would like, Dr. Lewis?
I wonder if in the next board meeting or the board meeting maybe after, since we have new board members here, that we could have a brief update again about PACE, because sometimes when we have our disciplinary hearings, we're sometimes still a little confused about what PACE is all about. So maybe just a very brief update again to remind us and to educate the new board members. Thank you.
Okay, any other? Ms. Willis.
Brenda Sutton-Wells. I'd like to have the Golden State Medical Association and Dr. Khadija Lang's issue of prescription access equity issues again come in the April meeting. I'd like to have that issue tabled and perhaps hear from the pharmacy board on that issue.
Okay. Thank you. Our goal was actually for Ms. Kirchmeier to contact pharmacy board and see it and bring it back to us, but we'll add it on. Thank you. Anything else?
When we do the PACE sort of reintroduction, if we could add on that neurosurgeon that came and spoke to us around doctors and aging.
Oh, yeah.
Yeah.
With reference to that, didn't we have Dr. Norcross give us a little update? Or no, it was Dr. Norcross's associate in a board meeting in the past.
Mm-hmm.
Okay. Any other? We are just adding the agenda, so keep going. Yeah. Because it's a good possibility Ms. Pines will be running that meeting. Okay, any public comment?
Because he's gone.
Okay, any comments on the phone?
No comments on the phone.
No, we're coming to the last agenda item. Adjournment, as I promised, it's 12:34. So we're done before 1. Motion to adjourn? Okay, all in favor?
Aye.
Any opposed? Thank you. We're done.